particularly first thing. So you please bear with us. We are citizen legislators, and we do, all of us occasionally get a little confused in this Zoom format.
And I will also say I really thought it was Friday today for many, many hours. So I think that just indicates how long a week we have already had, but it is in fact Thursday, May 6th. And I will now turn over the gavel actually for the Group 1 bills to Representative Tepler, as I am the sponsor of the first bill that we will introduce this morning.
Thank you very much, Senator Sanborn, and please go ahead and introduce your bill.
Okay. It'll just take me a moment to get there. Representative Tepler and my HCIFS committee colleagues, I'm happy to present LD 1681 on behalf of the administration. LD 1681 is different from the other bills being heard by our committee today. It's a foundational bill whose purpose is to ensure that our licensed healthcare providers may continue to use telehealth by embedding statutory authority to do so into each of the healthcare board licensing statutes. So this explicit statutory authority makes clear that telehealth as a means of healthcare delivery is within a healthcare provider's scope of practice. And the bill is designed to allow boards through APA rulemaking to set parameters for appropriate telehealth practices for each healthcare profession. I've spoken with the Department of Professional and Financial Regulation, and I know they and their boards feel a sense of urgency around implementing this bill and the proposed rulemaking. They're committed to moving as quickly as possible to ensure the ongoing and appropriate provision of healthcare services via telehealth. Thank you, and I'd be happy to answer any questions, although Commissioner Head will come behind me and may be better poised to answer specific questions about this bill.
Thank you, Senator Sanborn. Any questions from the committee regarding this bill? To Senator Sanborn. Yes, Representative Arford.
Yeah, thank you, Madam Chair, and thank you, Senator Sanborn, for this bill. My only question is, will there be a role for the public? If this bill is passed and becomes law, is there going to be a role for the public to participate in the development of these rules that will have, significant impact on the way in which they receive their healthcare services going forward?
So Representative Arford, the Administrative Procedures Act rulemaking process would be what is followed, and it absolutely allows for public comment as part of the development of the rules. I don't know whether utilizers of individual patients are all that frequently involved in APA rulemaking, but they are certainly invited to do so, and the process is designed to allow for public input of anyone who feels passionate enough to submit written comments or to go to the hearing on the rules when it is held. Representative Tepler, I just wanted to note that you should probably have Representative Libby introduce her bill before we hear from Commissioner Head as well.
Yes, thank you, Senator Sanborn, and thank you for being here, Commissioner. If you'll just hold on a minute, we will have the other bill introduced. So I invite Laurel Libby, Representative Laurel Libby, into the committee to introduce her bill.
I'm not seeing Representative Libby on the in the attendee list. Are you got, is anybody here?
Hmm.
I did send her a text. I can.
I don't see her yet.
Okay,
Well, then.
why don't go ahead, Representative. You do. My apologies.
Okay, then I think what we'll do is we'll hear from Commissioner Head right now, since I imagine that her testimony applies primarily to the department bill that they offer, but may also shed light on Representative Libby's bill. So please go ahead, Commissioner Head.
Thank you very much. Senator Sanborn, Representative Tepler, and members of the committee. My name is Ann Head. I'm the Commissioner for the Department of Professional and Financial Regulation and also the Director of the Office of Professional and Occupational Regulation. I'm here today to speak in support of LD 1681 on behalf of the administration and the department. I appreciate Senator Sanborn's willingness to sponsor this bill, and I will attempt to combine my testimony on both this bill and 1007. As Senator Sanborn has already indicated, LD 1681 has a different focus than other telehealth bills the committee will hear today. Currently, and importantly, our healthcare boards and their licensees do not have express statutory authority in their licensing statutes to use telehealth today. Healthcare licensees are only able to use telehealth during the pandemic by virtue of authority provided by the Governor's Executive Order 35. So the purpose of this bill is to make sure that when the pandemic is over, each healthcare licensing statute includes express authorization for providers to use telehealth to serve their main clients. I just want to mention that although the bill appears lengthy, it contains a separate section for each healthcare licensing board and uses the same statutory language in each board section. So you only have to look at the first page to see what the bill is about. It is a foundational bill. It provides statutory foundation for the use of telehealth by our boards. It also authorizes our licensing boards to use the APA rulemaking process to make sure appropriate guardrails are in place to guide licensees in their use of telehealth for protection of their clients. By authorizing boards to individually adopt certain standards and ethics that must be adhered to, the rules can be tailored to specific professions and situations. In my testimony, I've provided a few examples of what those rules might include, specifically establishing standards to ensure patient confidentiality, such as the use of HIPAA-compliant platforms to protect confidential information of clients. You can read the other examples at your leisure. The process of considering appropriate rules won't be a one-size-fits-all approach. Standards adopted by the Board of Occupational Therapy may differ substantially from those developed by the Board of Social Worker Licensure. Finally, I want to assure you, the committee and the public, that our boards are as eager as you to maintain telehealth as a method of healthcare delivery. We've all lived through the same public health emergency, and I encourage this committee to support LD 1681 to enable all DPFR health boards to use their collective expertise and discretion to adopt ongoing standards for telehealth appropriate for their practices and for the protection of their clients. So that's my testimony on 1681. It's really the first bill that needs to be put in place in order for us to move into telehealth as an acceptable service to our clients. With regard to, I don't know if this is appropriate, but I'm going to go ahead anyway. The department does oppose LD 1007 for a very simple reason. The executive order was put in place by the governor during the pandemic to make sure all Maine citizens were able to work with their health care providers without leaving their homes, basically. And the executive order did not include some of the safety standards, ethical standards, practice standards that each profession needs to observe. So it was a very good start, but it can't be the permanent standards moving forward. We do need to observe HIPAA compliant standards and many other situations that our licensees need to be guided by their board as to the ethical standards that would apply in various situations, and they're all different. So I would urge the committee to support LD 1681 as the best start and foundation for moving forward beyond the pandemic. So thank you very much, and I'd be happy to answer questions whenever.
So, folks, I'm getting the message from Representative Libby that she needs to give her testimony now because she's expected in another committee. So I'm going to ask you to hold your questions for Commissioner Head. Ask Commissioner Head to please stay in the panel and move to allow Representative Libby to present her bill. So welcome, Representative Libby. Please go ahead. We understand we're all busy these days, so go ahead and present your bill.
Thank you so much, Representative Tepler, for the consideration. I appreciate it. I will keep my testimony somewhat brief today. I have submitted it so you can see it in the portal. Senator Sanborn, Representative Tepler, and distinguished members of the Committee on Health Coverage, Insurance, and Financial Services. My name is Laura Libby, and I reside in Auburn and represent House District 64. I come before you today to present LD 1007, an act to increase availability of healthcare through telehealth. I've been a nurse since 2003, primarily in the ICU, as well as being part of a federal medical disaster relief team for over a decade. Though I'm away from the bedside now, over that time, I have seen many new developments in healthcare, but one thing generally remains the same: regulations that restrict and even impede medical care while increasing costs. Over the last year, we've seen unprecedented challenges here in Maine due to COVID-19, but I have been pleased to see some challenges to healthcare access eased via emergency orders. And I believe that we should use the lessons that we're learning from COVID and put in place policies that better prepare Maine for future outbreaks while improving our healthcare system now. While COVID-19 has given us some lemons here in Maine, I look forward to turning them into lemonade and ensuring that we continue to improve healthcare access in our state. On April 6, 2020, Governor Mills relaxed restrictions relating to telehealth and licensing in Executive Order number 35. And throughout COVID, this has enabled healthcare practitioners the ability to provide healthcare services using telemedicine or telehealth. Of course, not every healthcare need can be served with telehealth, but many non-urgent health needs can be with this modality. You can see, I don't need to read it for you, the list of folks who benefited from being able to use telehealth through this executive order. It's pretty extensive, and what I'd like to point out about this list is that many on the list relate to mental health. Given the shortage of mental health care providers in our state and the burgeoning mental health crisis, especially in our pediatric population, it only makes sense to maximize our providers permanently through these licensing and telehealth changes. That said, I would ask the committee, I ran out of revisers' edits to my bill, and one very important piece that was not included was what would now be an amendment to the bill that would add the following provision, also inspired by Executive Order 35. And that is that the board shall issue a license to any of the providers on this list, which of course you can read for yourself, who holds an active license issued by another state that is not a conditional license, has had no disciplinary or adverse action in the past 10 years involving loss of licensure, probation, restriction, or limitation, and is not the subject of any outstanding complaint or open investigation. The benefit of this quick licensing process throughout COVID has been great, but there has been one limitation. According to a March 1st Maine Public article, 50 mental health professionals sent a letter to the Maine Attorney General's office citing concerns about how long it takes to become licensed, saying the applications often take months to be processed. And as the would-be providers wait, so too must their clients at a time when the demand for mental health services is surging due to the pandemic. That has also been the experience for KDD, a licensed marriage and family therapist in Minnesota who was originally from Maine and is moving back this month. So essentially, while the executive order has been helpful, the licensing changes are set to expire 60 days after the conclusion of the declared state of civil emergency. That provision has made therapists like KDD who are seeing clients in Maine under a provisional emergency license reluctant to expand their clientele in our state when they know that their permanent license may be many months away and that the resultant coming licensure gap would make it impossible to serve their clients. I am pleased to report that since that article was published on March 1st, KDD has finally received her permanent Maine license, and we have gained a licensed marriage and family therapist in our state. So I have no ego attached to my bill. The end result that I want to see is that we're able to expand telehealth safely in our state. And if the other bill can do that, I'm happy to support it. The piece that I would like to see addressed in my bill is actually the amendment regarding licensing and continuing to ease licensing, particularly for these mental health care professionals who have had a provisional license during COVID and who are facing months-long waits to get their permanent license here in Maine, so that we can close that gap and make sure that we are not missing out on qualified practitioners from another state. So if these changes regarding licensing in particular can be done during a national health crisis, why can't they be done during stable times? I would like to see these regulations removed permanently and safely so that Maine people can access the care they so desperately need. I'd like to thank the Senators Stewart and Brenner and Representatives Craven, Madigan, Morris, Perry, Stover, Warren, and Zager for co-sponsoring this bill. Thank the committee for their time and consideration, and I'd be happy to answer any questions that you might have. I did include a link to the Maine Public article in my testimony, and that said, I am happy to answer your questions.
Thank you, Representative Libby. Does the committee have questions for Representative Libby? Representative Libby, I have a question regarding your amendment. Did you know that this committee had held hearings with Commissioner Head regarding the concerns expressed by those attempting licensure who complained to the Attorney General, and that we had identified along with the Commissioner the fact that she needed some additional personnel in order to process licenses more efficiently?
I was not aware. I am pleased that the committee is already addressing it. Again, I have no ego attached to this bill. However these ends are achieved, I just would be happy to see the result of licensing expedited for these professionals we so desperately need, and telehealth expanded appropriately. So whatever means the committee feels is appropriate that these changes can happen, I'm pleased to support. Thank you for the question.
Thank you, Representative Libby. Are there any other questions from the committee for Representative Libby? Seeing none, we thank you for your testimony. And I will turn back to questions that were addressed to Commissioner Head previously. Okay, I see that Representative Matheson still has a question for Commissioner Head. Commissioner Head? And Representative Matheson, I should say.
Thank you very much. Thank you, Commissioner Head. I just wanted to get clarification, and I'm not sure if I just missed this in the bill language, but telehealth how is that defined in this statute, or does audio phone, is that included in this? Because I understand HIPAA compliance was part of this language.
Yes, thank you for the question, Representative. The answer to the question is on page 1 of the bill, and I will simply refer you to the definitions section. And the definition of synchronous encounter means a real-time interaction conducted with an interactive audio or video connection between an individual and a person licensed, etc. What that means is interactive means telephone, any communication in which two individuals can speak directly to each other. That is permitted. It is not required. It would be the decision of the practitioner and the client as to what serves the client's needs most effectively.
Thank you, Commissioner. Are you set now? Yes. Okay, so I'll turn to Representative Arford for her question.
Thank you, Madam Chair, and thank you very much, Commissioner, for being with us today and presenting such a thoughtful testimony. My quick question is following up on the question I asked Senator Sanborn, who informed me that the public would indeed have a role, if desired, in the determination of the rules and how we move forward in evolving the practice of telemedicine in Maine. How would that happen? How would the public even be aware of the fact that these rules were being, promulgated, or how? I'm trying to envision that so that I can share it with my constituents.
That's an excellent question, and I think Senator Sanborn's response was right on. The references in the bill to rulemaking indicate that all licensing boards are required, just as all state agencies are, to abide by and comply with the Administrative Procedure Act with respect to public rulemaking. It's a really important point because I think there are many members of the public who are the beneficiaries right now of telehealth services that will be very interested in weighing in when there is the notification of a public rulemaking hearing. And we anticipate much more participation by the public in this subject matter because we have heard from our licensees that this is absolutely critical to keep a relationship with a client fresh and ongoing. With specific to your question, though, Representative, every time a board discusses, first of all board meetings are open to the public. It's in a remote setting, it is much easier for the public to listen to what's going on at a board meeting. Those public discussions of any rulemaking are also open to the public. So the public will know when a board is ready to offer a set of proposed rules out for public input. I know it's hard for some rulemaking to catch the attention of the public, but this is not one of those cases. So we do anticipate that we will have a great deal more of public input. And in terms of written comments and oral comments that we accept, and if there is a need to extend a comment period, boards always have the right to do that. And they also have to make comments for public display in certain documents that appear on the website for that board to notify the public what's coming up. Be prepared to come and talk to us, send us written comments. It's a very logical progression that the public can understand. And I think public comment right now, as we go through this process, is critical. Thank you.
Right. So just make sure I understand. So it would be posted on the different boards' web pages when these things are happening? Will it be posted in the newspaper? I mean,
yes, it will be on the board's website. We will put out Gov delivery notices to anyone who has signed on to that. There will be notices in the paper. I think right now we use the Portland Press Herald, and we also have it on the legislative weekly calendar. And we use the full array of public notification that we have used in the past successfully. So yes, I think if you look, I mean, I can certainly bring information back to you on the specific steps in that process, but the public will be notified that this is happening, not only through the public notification, but through their service providers.
Mhm.
I am sure that they're going to start talking to their patients about commenting, and it's profession specific.
Mhm.
So that's another way that we want to encourage public comment to make the rules more understandable and appropriate to that profession.
Thank you so much. That was an excellent response, and I am assured the public will be involved in this process. Thank you.
And the committee will be notified of all this. So, I mean, there are many ways of spreading this information.
Thank you, Commissioner. And next we'll hear from Representative Quint with a question.
Yes, thank you for being here, Commissioner Head. You actually answered one of them as one of my questions as far as whether or not the committee would be notified with each of the agencies, because that way we could also pass on that information. But my other question is, just as a nurse, I appreciate all that telehealth does. My only concern with telehealth becoming used so much that we lose the actual person-to-person meeting that I feel is strongly required in a lot of these different agencies that fall under the telehealth guidelines. So can you speak to that and just say whether or not during rulemaking that aspect of it will be brought up? I'm just thinking of making sure that someone is actually seeing a primary once a year instead of everything just being online, especially for those who don't really like to go out. And it would actually be a good thing for them to be encouraged to actually see their primary in person.
That's exactly right. And I didn't say that during my testimony, but one of the examples I've provided is there are certain programs, certain boards, the mental health board specifically, those boards might want to work with their licensees to make sure that telehealth is not the only method of serving the client. One of the kinds of standards that I think boards are already thinking about is making sure that at least there is an initial in-person communication together, speaking directly in person as a first step. It may be that follow-up meetings and discussions could be virtual, but that is something that the practitioner will need to clarify with clients, because it really should be the patient or the client's preference, not the provider's. So I would say that many of our mental health boards and licensees will want to see that kind of provision in a proposed rule.
Great, thank you so much. It was just one of those nagging concerns that I just couldn't get past. Thank you.
Yeah, it's right. Thank you.
And Representative Evans has a question.
Thank you, Madam Chair. Thank you, Commissioner. Just going back to something you mentioned earlier, that it's going to be board specific. And I think that's important because a lot of times we tend to think of telemedicine as a specialty, and it's not a specialty. As far as the Board of Licensure in Medicine, any physician who has a main license but lives outside of the state can use telemedicine already with patients in the state. And 52% of physicians licensed by the State Board of Medicine live outside of the state. So I want to make sure that we are not using a broad brush to rectify or potentially dismantle programs that are already in place.
Could I speak to that issue, Representative Tepler? I think that's a great point. And this sort of goes to something that Representative Libby said. There's no question that under this bill, 1681, a provider in another state that has a license in the other state plus a license in Maine will be able to continue to serve Maine clients. The related point that I want to explain is that we, in the office, we have issued over 2,000 emergency temporary licenses. And this goes to the concept of license by endorsement. Representative Libby was correct. That process should be, the process of making those licensees in other states part of Maine's service providers will be, I think, very quick. Many of our temporary licensees have already converted their licenses to full Maine licenses. So we've already started the process of that transition into full licensure in Maine. So I wouldn't want you to think that we are dismantling anything. We're trying to strengthen it to include out-of-state practitioners.
Yeah, I think I would agree with that because the issue of reciprocity, as long as someone doesn't have a record, would make it much easier for someone out of state who does not have a Maine license to get a license in Maine.
Right, and those out-of-state licensees have already been vetted to a certain extent, so it should be a fairly quick process, if they want a license in Maine to achieve that. And we've already converted some of our processes to take those license applications first because they can move quickly.
Yeah, thank you.
Thank you very much, Commissioner Head, for your testimony on these bills today. I am looking to the attendee list to see if there are any legislators who wish to weigh in on either of these bills. Yes, I see Representative Zager would like to weigh in, so he will be up next. Welcome, Representative Zager.
Thank you, Madam Chair. I, as we all are, I think, juggling between different committees. So Representative Tepler, Senator Sanborn, other honorable members, I really appreciate you holding this hearing. I'm Sam Zager, honored to represent District 41 in Portland and also serve my community as a family physician. Pleased to testify as a co-sponsor of LD 1007. Very appreciative of the Representative Libby, Senator Sanborn, Representative Tepler, yourself, and Representative Hymanson and others who introduced telehealth bills being heard today. I'm going to abbreviate my testimony from what was submitted in writing. Simply want to say that I co-sponsored LD 1007 because I, like others, believe we have an opportunity to be thoughtful in defining the contours of telemedicine as a mode of delivery as we go forward. The executive order has permitted lots of care appropriately during the pandemic, but the approach suitable for the pandemic likely needs to be refined as we look ahead to the eventual time when the current pandemic recedes. And I know this committee will be thoughtful about that. I provided in written testimony some vignettes from my primary care practice. I won't read those to you, but I will just say that we know, of course, that telemedicine has proven utility for sure, but also some limitations. And I thank you very much for your attention. Be happy to answer any questions.
Thank you, Representative Zager. Any questions from the committee for Representative Zager? Seeing none, we appreciate your testimony. Are there any other folks who are legislators in the attendee list who would like to testify on either 1007 or, got to go down to it, 1681? Seeing none, we'll move on to other proponents of the bill, and before bills, I should say. And before I do so, I would like to remind folks that we will be giving you only one opportunity to speak on both bills, and that we will, for non-legislators or members of the administration, be using a 3-minute clock. So with that, I will invite Louis Levy of Teladoc Health to present his testimony.
Good morning, Senator Sanborn and Representative Tepler and members of the committee. Thank you for the opportunity to speak to the committee on policy issues regarding telehealth. I'm the Chief Medical Officer of Public Policy and Strategic Partnerships at Teladoc Health. In this position, I am responsible for advocating for policies that support clinical quality and the patient experience through telehealth. I have more than 30 years of clinical experience and am a nationally recognized thought leader on healthcare innovation. I've had extensive experience as an internist in the Boston area and have taught at Harvard Medical School and other leading hospitals. I'd like to give you a little background on Teladoc Health. We are a global company delivering care in 175 countries, partnering with employers, hospitals, health systems, and more than 50 health plans in the US to transform care delivery. We are very proud of our contributions to healthcare in Maine. At an earlier time, we used to come up to Maine every summer as a family just to experience the Kiwanee in Weld. And we have a robust presence in your state. Over 2,100 employers offer Teladoc Health to their employees, and we cover over 110,000 lives in the state. In 2020, we performed over 4,500 consults and saved the healthcare system and the patients in Maine over $2 million. Your physicians are our physicians. All physicians who treat Maine patients are licensed by the Maine Board of Medical Licensure. Safety and access are our top priorities, and we take that responsibility very seriously. Good telehealth policy includes 3 very important pillars. The standard of care must be the same for telehealth as it is for in-person care. Secondly, the modality is not important as a standalone policy issue, but must support, again, the standard of care. Therefore, we always encourage policymakers to take a technology-neutral approach. Lastly, I tell policymakers that telehealth not only increases the access to quality healthcare, but it also brings savings to the patient and the payer. Teladoc Health believes that if a physician provides a service, they should be fairly compensated for that service. Telehealth providers like Teladoc Health and others don't have the overhead that a brick and mortar practice do and are able to provide our services at a significant savings. However, your local providers have invested capital into their practices in order to provide telehealth services, and it is not unreasonable to expect to reimburse them at a higher amount than you would a virtual-only provider. The bills before you today, with the exception of those that would require reimbursement parity, are quite good and speak to not only a technology-neutral approach, but contemplate issues such as licensure, the importance of asynchronous technologies, and the psychologist's interjurisdictional compact. All of these will improve access to quality medical and mental health services. Lastly, the only other recommendation that I would make to the committee is to consider including email and text in a limited capacity for mental health treatment and for use in remote patient monitoring. Experience has shown patients who would not normally seek mental health treatment will do so if the entry into treatment is text-based, with the goal of building up to a video visit. Patient adherence to therapy is greatly increased through the use of remote patient monitoring for diabetes and cardiovascular disease, if the patient can receive prompts and coaching relative to diet and medication adherence. Thank you so much, and I'll be glad to answer any questions.
Thank you for your testimony, Mr. Levy. Are there any questions from the committee? Yes, Representative Arford. You're muted, Representative Arford.
Sorry, that was a mistake. I didn't intend to do that. I apologize. Raise my hand. Hit the wrong button.
Okay, no problem. Thank you. All right, seeing no questions, I will move on to the next person testifying in favor of one or the other of the bills. And I will ask, let's see, Mr. Garrity to join us. You're here, Mr. Garrity.
Good morning, and thank you. Senator Sanborn, Representative Tepler, and members of the committee. My name is Bruce Garrity, and I'm here in support of this bill, both bills, although we do believe that some modification to each bill is appropriate. I'm testifying on behalf of the Maine Automobile Dealers Association, which has a self-insured MEWA, and Teladoc, although you've already heard from Dr. Levy, and I won't repeat his comments. As a matter of general principle, my clients believe in broad utilization of telehealth, not only including audio, but including other modalities. And you heard about texting, for example. My clients agree in the notion of parity in the scope of services, whether you are in person or remote. If you're within the scope of your practice, you should have the same ability to provide care to patients, but we do not agree with payment parity. We think there are differences, and the payment issue should be left to negotiation with carriers as long as care is provided within the scope of practice. We also don't feel that overly burdensome licensing or registration requirements are necessary given how interstate and even international care has become. Licensing is pretty similar state to state, and there are boards like Maine's licensing boards throughout the country. By way of specific comment, if you look at the synchronous encounter definition, which is one of them is on page 2, line 14, it's repeated for each of the practices. It references interactive audio or visual. That's where we believe that provision should be broadened. We also feel in discussing the licensing provision, again, you should look, the committee should look carefully at the question of whether it's appropriate to use a registration process or recognize licensing in other states. And indeed, I think expand the notion of reciprocity, which exists in most practices now. I would make one other point in response to a question Representative Arford asked earlier. One of the things that the committee can look to is Title V, Section 8053, which is the notice provision under the Administrative Procedures Act, and that delineates some of the requirements associated with providing notice to the public. With respect to LD 1007, I recognize that is broader than the scope of 1681. We do believe the breadth of the scope and recognizing that telemedicine should be available to the largest possibility is appropriate. And that's where LD 1007 went, and we think it has worked well. And I see my time is up. Thank you, Representative Tepler, and I'll be happy to try and answer any questions the committee might have.
Any questions from the committee for Mr. Garrity? Yes, Representative Morris.
Yes, thank you, Madam Chair. Thank you for being here, Mr. Garrity. You were just touching a little bit on the differences and that you felt LD 1007 was a little broader. Could you just speak to that and how you would want to see it broaden, some of the broadening applied to 1681?
Yeah, and thank you for the question, Representative. If you look at 1007, and we recognize that was an emergency bill, but it does relate to video, audio only, and other electronic media. That is the language that was used in the governor's emergency order. With respect to the other electronic media, we believe that that notion should be incorporated in the language used for specific boards. I would also say we think it's critical that the committee use whatever obviously believes appropriate, but we would urge you to use broad language in instructing the various agencies as to the scope you intend for telemedicine services to be available. I think if the boards understand the intent is to have broad availability, that can only help. And that is where LD 1007 came in. And I would also suggest perhaps the committee check with boards to see if there have been any complaints or problems associated with the scope of usage during the pandemic. I'm not aware of any, but I think that's information that could assist the committee. And I'm sure the department and its agencies would have complaint-based information. And thank you, Representative, for the question.
Any other questions for Mr. Garrity? Seeing none, thank you for your testimony, Mr.
Thank
Garrity.
you.
And the next proponent I will call is Kyle Zebley of the American Telemedicine Association.
Hello. Can you hear me okay?
Yes, we can, Mr. Zebley, and we can see you too.
Thank you so much, Representative Tepler, and thanks so much to the members of the committee. Really appreciate the opportunity to speak today. The American Telemedicine Association, for whom I'm the public policy director, respectfully offers this testimony regarding the telehealth bills that are now pending before the committee. The ATA is the only national organization completely focused on advancing telehealth, and we are committed to ensuring that everyone has access to safe, affordable, and high-quality care whenever and wherever they need it. The ATA represents a broad and inclusive coalition working to advance industry adoption of telehealth, promotes responsible policy, advocates for government and market normalization, and provides education and resources to help integrate virtual care into emerging value-based modalities. We are supportive of both LD 1681 and LD 1007, but I have a few ideas that could potentially be included. The ATA has a longstanding position that state policies related to tech-enabled healthcare delivery should be modality neutral and enable a healthcare professional to practice as efficiently and effectively as possible. In short, government should not pick winners and losers in technology innovation. Rather, it should set in place good public policy to encourage such innovation. This allows a practitioner to use their expertise, discretion, experience, and the standard of care to determine which delivery method will be the most effective for each unique patient. We urge the committee to consider a truly technology-neutral approach in defining telehealth, similarly to how LD 1681 does. As far as the rate of reimbursement for telehealth services is concerned, the ATA maintains that state policymakers should set rational guidelines that are both fair to the provider of such services and reflect the cost savings offered to the healthcare system by the effective use of telehealth technologies. In some instances, reimbursement parity may be appropriate, while other instances it may not be. Lastly, the ATA believes that all healthcare practitioners should be included under the telehealth umbrella. The COVID-19 pandemic has shown that it is not just doctors and their patients who benefit from remote care, but also mental, oral, and other physical health providers and their patients. To that end, the ATA encourages this committee to include all providers in any telehealth bill that moves forward. With that, I am available for questions, and I hope that this committee will continue to use the ATA as a resource when contemplating telehealth public policy. Again, thanks so much for this opportunity.
Thank you, Mr. Zebley. Oh, yes, we do have a question for you from Representative Matheson.
Thank you, Madam Chair. Thank you, Mr. Zebley, for your testimony. I'm just curious, as a practitioner who does telehealth, I'm wondering why, from your statement of there should be reimbursable differences, I'm curious how my overhead changes when I do telehealth. So I'm curious why you made that statement.
Yeah, no, absolutely. Thank you so much for that statement, Representative Matheson. We have come out very carefully towards this idea of fair payment because we recognize that there can be savings from not having brick and mortar overhead in some instances. But we also recognize there has to be a level of investment to get telehealth platforms off the ground and to continue to innovate them to ensure that they're delivering quality care. So we are not for payment parity at the moment. We think that there can be a level of flexibility when there are providers negotiating with other health systems, insurers, public and private, as to what that rate should be. We don't have an exact, there's no exact science from our perspective as to what that rate should be. We do think, of course, a doctor's time is a doctor's time. 10 minutes of a doctor's time is 10 minutes of a doctor's time. That should be reimbursed accordingly. So we're mostly talking about the facility fees or lack thereof that could be associated with telehealth. If that makes sense. Thank you so much for the question.
Are you all set, Rep. Matheson? Okay, great. Thank you. Thank you for your testimony, Mr. Zebley. Seeing no further questions, I am going to call Ms. Harvey McPherson of Northern Light Health.
Thank you. I totally echo that. Good morning. Can you hear me okay?
Yes, okay. We can.
Okay, good morning, Senator Sanborn, Representative Tepler, and committee members. My name is Lisa Harvey McPherson, and I'm here to testify in support of 1681. And I understand while I have other comment on other bills, I will return to the committee and testify in those sections. Is that correct?
If you are also testifying on 1007, we'd appreciate your testimony at this time.
Okay. So as I worked on testimony, and I submitted one comprehensive testimony on all the bills, so I'll be back. I originally recorded support for 1007, and I'm not saying that I don't support 1007, but as I looked at 1681, it seems to me that 1681 achieves the policy goal of adding to the licensing and professional practice standards that telehealth is accepted within the scope of practice for the levels of clinicians defined in the bill. For Northern Light Health, during the pandemic, we've significantly expanded telehealth. We're averaging about 20,000 telehealth encounters a month right now. Many of them primary care, clinician-based, but the opportunity that we had to expand pharmacy, physical therapy, occupational therapy, and psychology as some of the professions supporting patients through technology at home, we've learned a true valuable lesson on the role of expanding the breadth of the clinicians that can do telehealth service. So whatever the policy vehicle is, and I think it's 1681 to do this, we are in full support. If the other bill, 1007 is the vehicle, then we would be in support. I just thought that this one was clearer and was a stronger approach to the policy goal. And with that, I welcome any questions that you have.
Thank you, Ms. Harvey McPherson. Any questions from the committee for Ms. Harvey McPherson? Seeing none, we appreciate your testimony. And we will ask, hang on one second while I choose the next person from the list, please. We will ask Michael Dixon of Auburn to present his testimony.
Hi, I'm here and I'm working on getting my video started. Here I am.
There you are. Thank you for being here.
Yes, and I'm going to, I have submitted the transcript of my oral testimony that I was going to give, and I'm just going to throw that all out the window because I want to respond to some things that we're saying. Representative Matheson, I share highly your concern regarding not parity and quality between telehealth. Demanding that, I think, is great and wonderful and completely appropriate and necessary. But I don't get either about parity and reinforcement not being part of that, or parity in reimbursement, excuse me. Which is reinforcement for private practitioners. So I have concerns about that. I'd also like to say, I mean, if you want to have a good body of people who are able and effective at delivering telehealth services, one of the things that you'll need to do, again, when you're dealing with small agencies and private practitioners in other states, you're going to have main care reimbursements have parity with the reimbursements of Medicaid in those people's home states as well. And there was a Bill 592 that is trying to address that issue in HHS. I'm very supportive of the idea of having high licensure standards for all people who are delivering telehealth services. I think that protects the public, gives them a forum for seeking help if they think they've been harmed. I also want to address Representative Quint's concern about having a face-to-face. And I agree with that 100%, except that during the pandemic, that really wasn't an option. And what we discovered is that even new patients, after you help them to get comfortable with the technology, they glommed onto the services and really like them. And several, I surveyed several of my colleagues who are less retired than I am, who said that they were able to complete the therapeutic process in a timely fashion from intake to termination and address the certain problems. And there may be certain diagnoses that won't work with, and I get that. And also I like the idea that people should see their primary, I'm sorry. Okay, I'm going to stop here because I'll be back later in the day. I'm here for group 4 too. Thank you.
Thank you, Dr. Dixon. Any questions from the committee for Dr. Dixon? Yes, Representative Quint, please go ahead.
Not so much a question, but a statement. Thank you for referring back earlier to my question. I'm glad to hear that that's worked in a lot of situations. I still have, in some of the areas, I still have some reservations, but specifically what you're saying, I'm glad to hear that that's worked out during the pandemic, especially with the mental health issues that we've been having in our state. Thank you.
Yeah. May I say something else? Psychotherapy is much less hands-on than a lot of other medical procedures. So there may be something about counseling, social work, psychologists that's a little bit different than many other medical practitioners. or physicians and
Thank
nurse practitioners and so on. All right. Thank you so much for having me, and I will see you later in the day.
Thank you, Dr. Dixon.
Bye-bye.
And now we will turn to Jasmine Bishop of Maine Health, speaking in favor of 1681.
Can you guys hear me okay? Good morning.
Yes, good morning, Ms. Bishop. Welcome.
Thank you so much. I appreciate the opportunity to testify today. Senator Sanborn, Representative Tepler, and distinguished members of this committee. As you said, my name is Jasmine Bishop. I'm the Director of Telehealth at Maine Health, and I'm here today to testify in strong support of expanding coverage and maintaining payment parity for telehealth, including video visits and audio-only visits and telemonitoring services, because it will help increase access to healthcare for our rural Mainers. My testimony today generally addresses each of the bills you will hear today, but I would first like to say that we are grateful that the administration has been proactive in supporting telehealth through MaineCare and requirements on commercial health plans during the pandemic. Because of the flexibilities provided, we have learned an incredible amount about telehealth and what works best for our patients and their clinical needs, and our position on these bills reflects those learnings. Since the start of the public health emergency, Maine Health has conducted more than 200,000 video visits to patients' homes. We continue to conduct 20,000 visits per month. Maine Health has also conducted over 100,000 phone visits. While we always seek to offer video visits when possible, we acknowledge there are many cases in which a patient may need a phone visit, including patients without access to adequate broadband to support the significant data required for video, patients without the financial resources to afford an adequate data plan, patients without the necessary video-enabled devices, and patients without the technical literacy to navigate telehealth visits, a particular challenge among our older population. We've received telehealth surveys from over 13,000 patients over the last year, and 75% of these patients indicate they would recommend the service to their friends and family. In a telehealth patient survey completed just yesterday, May 5th, a patient wrote, "The Wi-Fi where I wasn't great, so we finished the appointment on the phone." This patient was seeing a provider in Portland. Access issues occur throughout our state. In a survey submitted December 26th, a patient stated, "It is a lifesaver to have virtual appointments as we live on a remote island and it's difficult to travel at times." Moreover, telehealth is sometimes the only way to reach patients who would not have otherwise come into the clinic setting. This can be particularly true for behavioral health patients. As an example, no-show rates for behavioral health patients being seen in person is 15.2% at Maine Health, while no-show rates for phone visits is only 2.9%. For patients without even phone access, we purchased phones for those with substance use disorder because they did not otherwise have access to those services. When we segment services based on patient resources, we decrease the access to care for patients without adequate resource and increase the digital divide. As a healthcare system with all eligible hospitals receiving Leapfrog A safety ratings or Best Rural Hospital designations, we are committed to ensuring quality of care in all interactions with our patients. Telehealth is simply another means of providing care, but the standards should not change based on the medium through or by which the care is delivered. Licensure protects patients where the provider is in person or in another state. A patient who receives telehealth from a provider in Maine should expect that the same quality and oversight standards apply as if the visit was in person. Licensure governs that oversight. In order to maintain equitable access to all patients.
Wrap it up for us.
Absolutely. I was just going to end with that payment parity acknowledges the equivalent level of care is being achieved. I know we've had some discussion on this point, but we do not close any doors and we have the same level of overhead to provide these telehealth visits. Thank you so much for the opportunity today. I welcome any questions.
Thank you. Any questions from the committee for Ms. Bishop? Yes, Representative Matheson.
Thank you very much, Madam Leader. Just real quickly, do you have data on people of color in terms of how telehealth has helped? Have you broken that out for disenfranchised groups as well?
You're on mute.
Certainly get that data for you, Representative Matheson.
Thank you.
Thank you, Ms. Bishop and Representative Arford.
Yes, thank you again, Madam Chair, and thank you, Ms. Bishop, for coming before us today. I had the opportunity to speak with you earlier, and I am very much in awe of your knowledge and your passion for telehealth, and so thank you for that. I am still very interested in specific patient data collected directly from the patient in some sort of patient survey that really gives us a sense of where patients who have experienced both video conferencing and teleconferencing for medical care, what their experience was of that. And when I spoke to you earlier, it was my understanding that you were in the process of collecting that. And if you do have anything you could share with us, I would greatly appreciate it. But I'm specifically talking about their responses to receiving both of those different modalities, but separately. In other words, that they'd be responding on one or the other, not both at the same time. And then the other thing is, I wanted to know if you have access to any data from other states that are doing the same thing, or maybe even are ahead of us at this point in opening up services more robustly. And if you have any data collected by other states, I would appreciate that as well.
That's a request, Representative Arford, for the work session.
If it's possible, for any of these bills, is it most likely that we'll be hearing these bills together in a work session? Or will they be, I'm just wondering the time frame, because it may take a while I understand, Ms. Bishop, it may take a while for you to do this. So it would be great if we could have that data by the work session. That would be terrific. But I also understand it may take you a while to put it together. I think it would be great for our committee. I think our committee will be addressing this issue for a while. And I think it'd be great for our committee to have this information as soon as it's possible to get it.
Okay, thank you, Representative Arford. So we'll sort of put that request out generally to Ms. Bishop when she's before us to provide us, if she can, with that information. I'll turn to Senator Brenner.
Thank you, Madam Chair. Thank you, Ms. Bishop. I'm curious if you could tell us a little bit about the experience for folks who are non-native English speakers on telehealth and how that works, and whether that experience for them is beneficial, if there's been any feedback from non-English speaking community about their experience with telehealth.
Thank you for the question. That is definitely top of mind for us. So we have a great workflow that allows interpreters to join our video visits, whether they're interpreters that are within our system or subcontracted interpreters. And Zoom also, we use Zoom as well for our video visits. It also allows for transcripts so that our patients it's not just English as a second language or a non-native English speaker, I should say. It's also for those patients that are hard of hearing too. That's a question that comes up as well. So we get live transcripts that can play while the video visit is occurring.
Are those transcripts downloadable for the client after the visit?
That's a great question. I'd have to check on that. There's a lot on our version of Zoom. I should specify what we use for healthcare is different than what is used in the community. And so there's a lot of mechanisms that are turned off, like chat can't be downloaded for concerns of PHI or personal health information. So I'll check on that.
Okay. Would there be any reason why it might be important for us to want to mandate something like a transcript from a telehealth visit for a client to be able to have access to afterwards?
That's an interesting question. Let me think on that and get back to you on that question as well.
Okay. Because I sometimes, I've found that you don't always hear everything the first time it's said. I wonder if the transcript might be handy.
I will acknowledge that after every one of our visits, our patients receive their after visit summary with a detailed list of all of their what was discussed during the visit. And since a recent law passed that allows patients also to get all of their doctor's notes in their patient portal in our MyChart system. So they have a lot of access to the data that's in their chart.
Great. Thank you so much.
And next up, Representative Brooks.
Yes, I had a question. I heard that in your testimony that you help with communication devices or service for people that might not be able to afford that. Can you just describe, that's a great service, but can you tell me a little bit more about that?
Thank you for the question, and I'd love to because it's a passion project of mine. So our team last year, our larger team, did a great pilot project giving smartphones to patients that had substance use disorder, as I shared in my testimony. Since that was so successful, we are looking towards grant funding to expand on what we're calling our patient device lending library. And that is a program that would allow for patients to receive not only video-enabled devices, but also those with data plans to address both the issues of device resources as well as broadband resources.
Could I have a follow-up, please?
Yes, please go ahead.
Yeah, and are they able to use the phone to also connect with emergency services and other types of communication, like with family, friends?
That's a great question. It's one that we're still grappling with, and I think you're getting at the will the device be quote unquote locked down to only be used for video visits or for healthcare? And so as we're developing this program, we'll consider the best way to ensure that we're giving resources to help the patient in all aspects of their life, including access to family members.
I'm just going to briefly remind committee members that we have a lot to do today, and let's try to focus our questions on the bills at hand. Representative Arford, with that, I'll turn back to you again.
Thank you. Thank you for that reminder, and I'll be very brief. For the people who you mentioned who are living in the areas where they do not have broadband or any sort of internet access, and they are only able to do the telephone medicine visit, would you be able to provide them with a mailed version of their case notes? Because they would not be able to. Do you do that for people? Do you?
Yes.
Okay. That's all. Thank you.
Great. Thank you, Representative Arford, for your brevity, and thank you, Ms. Bishop, for being here to testify. And next, I will turn to Patsy Katsos of the Maine Academy of Nutrition and Dietetics.
Hi there, can you hear me?
Yes, we can, thank you.
Good morning, Senator Sanborn, Representative Tepler, and distinguished members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Patsy Katsos. I'm a resident of Portland, and I'm here today on behalf of the Maine Academy of Nutrition and Dietetics in support of LD 1007. The Maine Academy is an affiliate of the Academy of Nutrition and Dietetics, an association that represents over 100,000 credentialed dietetic and nutrition practitioners. In my own work as a registered licensed dietitian, I'm a consultant at Nutrition Works in Portland, providing one-on-one medical nutrition therapy to patients with gastrointestinal problems. Well, we found that telehealth as permitted during the present emergency has been a big improvement for our patients. Before the emergency, insurance coverage for telehealth services was really hit or miss due to what we consider loopholes in the previous telehealth law. Most patients decided not to receive telehealth services when we had to tell them that we weren't sure whether their insurance would pay for it. And patients who lived far away were often lost to follow-up because of that. So we do support LD 1007 and act to increase availability of healthcare through telehealth with some changes that we recommend based on our pre-pandemic experience to allow patients to access their benefits. First of all, we encourage that there is assurance that the telehealth provider could be one of the patient's choice as for in-person visits. Before the pandemic, some payers were able to meet the letter of Maine's telehealth law by offering telehealth nutrition services only from their own employed health coaches or contracted national providers who were unlikely to be known to the referring physician, who's currently referring to the local provider, and who may lack the required specialist expertise that the patient needs. So payment parity is really important here to keep Maine patients seeing Maine providers with appropriate expertise when possible. Also, we would like to ensure that all health insurance carriers are required to cover telehealth for nutrition services, including the many, many plans that are, ensuring Maine patients, which are self-funded or are written out of state for companies that are headquartered elsewhere. And those were some of the situations in which it was extremely difficult for us to determine whether telehealth would be covered for a patient. They were often excused from the requirement to cover telehealth. So in short, we urge you, the members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services, to support LD 1007. Thank you, and I welcome your questions.
Thank you, Ms. Katsos. Any questions from the committee for Ms. Katsos? And I just have one reminder for you, Ms. Katsos, and that is that this committee does not have the ability to force plans that are under federal jurisdiction to abide by our policy goals. Those plans, particularly the ERISA governed self-funded plans, are out of our control and only within federal jurisdiction.
Thank you for that clarification.
Yes, well, it has been an ongoing concern in a number of areas.
Yeah.
Okay, so are there any other questions from the committee for Ms. Katsos? Seeing none, thanks for your testimony. And I will call Alexander Chu to testify in favor of the bills.
All right. Thank you very much. I appreciate the opportunity to speak. I'm Alexander Chu. I'm an emergency medicine doctor. I also run a telehealth practice, air visits. So work in the ER, also run a telehealth practice. And this testimony is in favor of 1681 and 1007 to also amend it for emergency procedures to require physicians and other providers that if during a telehealth visit, there's an emergency, you should coordinate that emergency the same as you would in person. And we think it's common sense, but we have found that many providers, hospitals, telehealth programs do not have emergency procedures to be able to handle emergencies. So if a person has a chest pain, stroke, which is very not common during a telehealth call, but when it does happen and you're suicidal or a patient is suicidal, that you should be coordinating that emergency. And I have an illustrative case for it. So I've been seeing a patient for the last year now, and she has a lot of primary care problems, depression, hypertension. So we referred her out to a psychiatrist and a therapist. And this past January, a few months ago, she told her psychiatrist over a video visit, she said, "I want to kill myself. And I want to take a whole bunch of pills." And the psychiatrist said, "Yes, this is an emergency. You need to get into the hospital. Your depression is unstable, and we need to get you stabilized. I need you to hang up and call 911. So they hung up. She didn't call. Weeks goes by. Now she calls us, and she had already taken a bottle of hydroxyzine and a whole bunch of over-the-counter pills. And we say, "Well, we're actually advocating for this emergency a protocol. You definitely called the right practice. We coordinated 911 to be able to go to her house. EMS showed up. She was so somnolent that she couldn't even make it to the front door. We coordinated with police to be able to enter. We got her out, got her to the hospital. She survived, and she was a lot luckier than two other patients that we know of. That one jumped off a building, the other one jumped off a bridge. Both of them had a lot of telehealth visits right before that, and both of them died. So in our written testimony, we sent over some proposed language saying, if you're doing a telehealth visit, you should be one to the physician or provider needs to be able to coordinate that visit. Now, I called that other practice because it was our patient afterwards and said, I'm going to help you. I have all the protocols. I have every 10-digit phone number you'd want. I have all of the protocols on how to identify the emergencies. Let me just give it to you. So you have this because we're taking care of common patients. And they said, well, we'll consider it. And I said, well, you're going to consider it. Do you do this in person? There are guidelines in person. The Joint Commission has guidelines on handoff procedures. There's in-person guidelines around how do you coordinate emergencies? How do you hand off patient care? And he says, well, of course, in person. If someone's in my office and they had a problem, I would absolutely do it. But those don't apply to telehealth. And just wanted to end there with saying, and we've talked to a lot of other hospitals too in their compliance departments, and they said, yeah, that's absolutely right. Those guidelines don't apply. So I'll open up for questions, but thank you. I'd like to be able to add that amendment onto 1681, please.
Thank you, Dr. Chu.
Thank you.
And I will ask the committee if they have any questions. And I guess I would hope you'll be available for the work session.
Yes, that would be great.
Or to submit your comments in writing so we can have them to think about as we proceed.
I've submitted already, but I'd be happy to join the work session as well.
Great, thank you. Thank you. Any other questions from the committee? Seeing none, that brings us to the end of those wishing to testify for either bill. Yes, Mr. Ritchie, is there?
I was gonna ask if we could get what town he is from or what organization he was representing.
I'm sorry. Let's see if we can do that. Mr. Chu, Dr. Chu, we're gonna bring you back in for a second. Can you just tell us, Dr. Chu, where you're from or what organization you represent, or both, preferably, actually? You're on mute.
There we go. All right. Thank you. I'm currently in New Jersey. My practice name is Air Visits. We have about four providers. Do a lot of advocacy through the American College of Emergency Physicians and other organizations. And right now, looking at the states that we are involved with to be able to add on these types of other requirements.
Okay, and where in New Jersey?
Actually, Little Falls.
Little Falls, New Jersey. Okay.
And also New York City as well. So both sides.
Okay. Thank you very much.
Mm-hmm.
All right. And so having finished with the proponents of the bill that I have listed, I will turn to the attendee list and ask if there's anyone else. Oh, I see someone else who would like to testify in favor of the bills, and welcome Ms. Morse to join us. Ms. Morse? Yes, her wormhole trip is just a little longer than others. Okay, welcome, Ms. Morse.
Good morning. Senator Sanborn, Representative Tepler, and the members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Caitlin Morse. I'm a resident of Westbrook and the Policy Associate of the Alliance for Addiction and Mental Health Services. I am here to read testimony on behalf of Mallory Shaughnessy, the Executive Director of the Alliance for Addiction and Mental Health Services. Please accept this testimony on behalf of the Alliance in support of LD 323, 333, and 849. And
Ms. Morse, those are not the bills we're discussing right now.
Oh gosh. Oh, I'm horrified. Okay. I am so sorry.
We will call you back when we discuss those bills. Right now we're discussing 1007 and 1681.
Okay, thank you.
Thank you. Thank you. We'll call you back when the time comes. Thank you. So I am returning to the attendee list again, to those with us on the Zoom call, to ask if there is anyone else there who would like to testify specifically on LD 1007 or LD 1681 in favor of either of those bills. Okay, seeing no one wishing to testify in favor, I will turn to those testifying neither for nor against and call Mr. Grayboys of the Mercatus Center. Welcome, Mr. Grayboys. Could you please just say where you're from?
Surely, I'm in Alexandria, Virginia. I'm a senior research fellow at the Mercatus Center at George Mason University.
All right, please go ahead.
Thanks. Good morning, Chairs Sanborn and Tepler and members of the committee. I'm delighted to testify on Maine's proposed healthcare legislation, in my case, both LD 1007 and LD 1194. As I said, I'm Robert Grayboys, Senior Research Fellow at the Mercatus Center. My wife and I began visiting Maine in 1981. We became engaged there in 1984 and return every chance we get. We love the vastness and the sparseness of the terrain, the mountains, the islands, the isolated villages. But the remote beauty, everything that we love about Maine, can make access to healthcare profoundly challenging. Over the past 14 months, healthcare delivery across America changed radically as we raced to confront the COVID-19 pandemic. We began and only began to discover the power of telehealth. We temporarily discarded antique conventions regarding professional licensure, scope of practice, professional autonomy, certificate of need, and reimbursement. For all its horror, the coronavirus forced us to learn that new technologies and innovative institutional structures offer unprecedented ways to deliver care, ways that are ideally suited for a place like Maine. These innovations offer multiple ways to reduce healthcare costs, though they won't necessarily reduce aggregate healthcare spending over time. Now, if these two bills were to pass, Maine would permanently welcome out-of-state and recently retired physicians, physician assistants, and nurses, including those with osteopathic training. Audio-only visits and asynchronous technologies would fall within the definition of telehealth. Advanced practice registered nurses could work without supervision or collaborative practice agreements, and nurses could provide care via telehealth. All of these actions would enhance Mainers' access to timely care, but beyond that, they would help you to absorb future delivery system innovations as they appear. I'm confident that 10 to 15 years from now, the telehealth of 2021 is going to look primitive. Recently, I've commented upon similar legislation in several other states. These two bills, along with the roughly 10 others currently before you that I've seen, are the most comprehensive reforms that I've seen in any of these states, and I commend you on your efforts. Thanks, and I'll be glad to take any questions.
Thank you very much, Mr. Grayboys. I will turn to the committee and see if there are any questions. Seeing none, thank you for your testimony. And my next person up to testify is the Superintendent of the Bureau of Insurance, Mr. Chapa. Welcome, Superintendent.
Good morning, Representative Tyler.
Tepler rather, and members of the committee. I am Superintendent of Insurance Eric Chapa. I'm here to testify today neither for nor against LD 10007. I won't read the part of my testimony that describes the bill, and if that's all right with the committee in the interest of time. But this order, on March 20th, 2020, I issued an emergency response order specifically concerning telehealth. This order followed up on my original order, and it allows audio-only telephone visits and requires carriers to cover in-network services at parity levels with in-person network services for the duration of the COVID-19 emergency. I would also note that in light of the pandemic at the federal level, CMS has loosened restrictions around HIPAA privacy requirements to encourage telehealth services. Finally, the governor's bill on telehealth, LD 1680-81, is also being heard today because not all provisions of the executive order are appropriate beyond the duration of the emergency. LD 1681 provides for the expansion of telehealth services, but with input from relevant oversight boards on appropriate standards and restrictions. Thank you, and I look forward to working with the committee on telehealth issues. I'm happy to answer any questions.
Thank you, Superintendent. Any questions from the committee for the superintendent? Yes, I see several. Representative Matheson, please go ahead.
I'll keep mine small, I promise. Just the same question I had for Commissioner Head. I wanted to make sure that the statute in 1681 did include audio only. Is that correct, Superintendent?
Commissioner Head is better able to answer that than I am.
Okay, should we ask Commissioner Head to respond to that at some point? No. Okay. No, thank you. We will turn to Representative Arford with a question.
Yeah, thank you very much. I'll be, again, as brief as possible. Have you considered, Superintendent, in I wouldn't call it promoting, but in allowing for the telehealth medicine to be paid for on a parity with delivered in-person healthcare, that certain services such as follow-up calls after a patient receives some lab work, or coverage services that have traditionally been offered by every primary care specialty practice everywhere after hours, where patients can call in for help when they're not offered, that those services might now be billed, and that then there would need to be some sort of a study to determine because in fact it would be creating new covered services. And that we would need to determine what the increase in cost would be, just like any other service that would require, say, a mandate study. Have you considered that?
Well, that's an excellent question, Representative. I think first some context around my order. My order was strictly in regards to the pandemic, and we felt very strongly that people still needed access to care, and the legislature had previously decided that parity in coverage was required, but they didn't address payment parity, and we decided to mandate under my emergency authority payment parity. But I think you raised valid points. I mean, we're not aware of any utilization issues, but I think you raised valid points. If we have payment parity going forward, what is going to be the effect on price and utilization? I think that's a legitimate question. I don't really have any data analysis that demonstrates the effect one way or another, but those are important questions for the committee to consider.
Thank you.
Any other questions from the committee for the superintendent? Seeing none, is there anyone else in the Zoom call who would like to testify either in opposition or neither for nor against, or in favor of these bills? Seeing none, that brings to a close our hearings on LD 1681 and 1007. The committee will take a 40-minute lunch break now and return at 12:30 to complete our work for the day with two more, or is it, yeah, two more sets of hearings, or three more sets of hearings, I'm sorry. Three more sets of hearings. Yes, so 40-minute lunch break now. Please be back at 12:30 for LD 863. Thanks, everyone.
Okay, it's 12:31. And we've got a ways to go before we finish our day. So if the committee can hear me, you can turn your camera on and let me know you're back from lunch. We have 2 Representative Blyers. All right.
Hey, Heather.
Yeah.
It's Representative Blyer. I had to leave and I'm coming back and I'm on my cell phone. That's why you have 2 and then shut my computer off. So I am here
Okay.
though.
Great.
Yeah, thank you.
Yeah, Representative Blyer, are you going to go back to your computer? Because I can just kick you out of the meeting from here if you want.
You can do that and I can rejoin when I get back.
Okay, great.
Thank you.
Oh, the clerk told me not to do that, so I'm not going to do that. Good catch, Christian. I won't do it. I think it won't let him rejoin if I kick him out. I see. Yeah. Okay, perfect. So we'll just have a couple of Mark Blyers in our view on the panel for now, and we do have 8 members of the committee back, so 9 members of the committee back, so we can get started. The next grouping of bills that we're going to hear today is really just a single bill. For those who might have joined late, I will have Christian drop the order of operations and the groupings into the chat again for today, or Colleen, whoever has that handy. But the next bill is LD 863, an act to have Maine join the Interstate Psychology Interjurisdictional Compact to improve telehealth options for psychologists and their patients. Not the longest bill title that we have heard, but close. It is sponsored by our co-chair, Representative Tepler, and it is going to be heard by itself as a group, and then we'll have 2 more groupings of bills on telehealth today. So with that, Representative Tepler, you may go ahead.
Thank you very much, Madam Chair. Senator Sanborn and respected colleagues of the Health Coverage Insurance Financial Services Committee. I am Denise Tepler. I represent House District number 54, which is all of the sweet town of Topsom. And I'm pleased to present LD 863, an act to have Maine join the Interstate Psychology Interjurisdictional Compact to improve telehealth options for psychologists and their patients. Interstate licensing compacts in general can improve efficiency and effectiveness of Maine's professional licensing programs. They can provide benefits in limiting the amount of work licensing boards must do checking out-of-state credentials, and can allow more opportunities for Maine-based professionals to do work in border states while protecting patients from unscrupulous practitioners. PsyPact, which is what this bill is about, in particular, is an interstate compact which provides a mechanism for the ethical and legal practice of telepsychology by licensed psychologists whose states join the compact. I've heard varying numbers of states have joined the compact between 15 and 20, and certainly at least 11 more, including Vermont, have pending legislation. New Hampshire currently belongs to PsyPact. Joining PsyPact will offer our fellow Mainers more opportunities to obtain the highest level of mental health services from doctoral level licensed psychologists, including those with specialties like opioid use disorder. Thank you for the opportunity to present this bill. I will be happy to answer any questions you have, but members of the Maine Psychology Association who asked me to sponsor this bill are present in support of the bill and may be better able to answer your questions. Please note that the Department of Defense has submitted written testimony supporting the bill.
Thank you very much, Representative Tepler. Are there questions for the sponsor of the bill? Okay. Next, we will hear from Amy Safford from the Maine Psychological Association. Go ahead, Ms. Safford.
Thank you. Good afternoon. I'm Amy Safford, the Executive Director of the Maine Psychological Association. On behalf of MEPA, I'd like to thank Chairpersons Sanborn and Tepler and distinguished committee members. Also, special thanks to Representative Tepler for sponsoring the bill. The passage of LD 863 would permit Maine to join the Interstate Psychology Interjurisdictional Compact, known as SIPACT, a crucial step in providing Mainers with access to quality psychological evaluation and treatment, and permitting Maine psychologists to follow their patients who may leave for college, work-related, or personal reasons. As Representative Libby said earlier, it can take several months for both in-state and out-of-state psychologists to be licensed in Maine, or for Maine psychologists to be licensed in another state. It's important to note that only the compact bills you're hearing for psychologists and OTs help Maine practitioners work across state lines. Psychologists must apply for and obtain either an e-passport to provide telehealth services or a practice certificate to provide temporary face-to-face services for a 30-day period in other SIPACT states. They must be licensed, have acceptable levels of training, and be in good standing in their home state without any disciplinary action on their record to be eligible for credentialing. They will continue to practice under the authority of their home state license, but must abide by the scope of practice in the receiving state where the patient is located. The compact does not interfere with the state's right or ability to license and regulate in-state practice. When there's a conflict between states around laws and regulations, psychologists will follow those of their home state. SIPACT rules only apply to the narrow confines of interstate telepsychology or temporary practice. All other aspects of psychological services remain the exclusive purview of the Maine Board of Examiners. States can alert the Commission about any misconduct, and psychologists can be barred from continuing to practice into other SIPACT states. The psychologist's home state will enforce disciplinary action by consulting with the state where the alleged misconduct occurred. Every state that joins the compact has an equal voice in the SIPACT Commission by appointing a representative who participates in and votes on all actions. SIPACT has been approved in 20 states, including New Hampshire, as Representative Tepler pointed out, and 11 more have legislation pending, including Vermont. CMS approves multi-state licensing compacts, and the American Psychological Association strongly supports the adoption of SIPACT. We urge this committee to join these other states for the benefit of our residents who need mental health treatment they cannot otherwise access, and for licensed Maine psychologists to provide continuity of care to their patients wherever they may be. Thank you for your time today, and I'm happy to answer any questions.
Thank you, Ms. Safford. I have a question which comes from previewing the testimony of our board of counseling professionals. She wondered or asked about the work that we have done to ensure that international applicants and who might have been trained in other countries have access to licenses in Maine. Can you explain as to whether we would give up on those gains that we have made in equity here in Maine if we were to join SIPACT?
Thank you, Senator Sanborn. That's an excellent question. I'll have to double check with the ASPPB, which is the governing board for SIPACT, the Association of State and Provincial Psychology Boards, but definitely Canada is included in SIPACT. So any psychologist practicing in Canada would be included. And I'll have to double check on other international practitioners, but I will get back to you.
Is it possible to have a license in Maine after we pass SIPAC that doesn't meet the standards of SIPAC? Or is that what's prohibited?
Is it possible to have a license in Maine even if you're not part of SIPAC? Is that what your question was?
No, I'm not articulating it very well. You talked about the things that the licensing board retained in terms of sort of in-state practice. Is it possible for foreign trained professionals to still practice in-state even if they wouldn't qualify for SIPAC rules?
I believe that could be written into the Maine licensing law. If it's already there, then that SIPAC wouldn't change that.
Okay.
But I will get clarification. Those are great questions about international practice.
Okay. Representative Tepler, did you want to say something? It's your bill, so we probably shouldn't do that. Okay. Are there other questions for Ms. Safford? Okay. Great. That'll be something we can figure out at the work session. Next, I have Thomas Cooper on my list to testify. Go ahead,
coming
Mr.
through?
Cooper. Yes,
Okay.
go ahead.
Excellent. Good afternoon. I'm Dr. Thomas Cooper, President of the Maine Psychological Association. I'd like to thank Chairs Sanborn and Tepler, as well as the committee members, for the opportunity to discuss SIPAC with you. I know how busy you all are, so I'll be sure to keep my testimony brief. As you are well aware, we're experiencing unprecedented demands on our healthcare system. While we continue to make remarkable strides with combating COVID-19, the psychological consequences of the pandemic will be long-lasting. The American Psychological Association warns of acute difficulties with behavioral health and substance abuse crises, and has been advocating for psychologists to evolve the way evidence-based services are delivered. SIPAC is an example of such evolution. As both the president of the Maine Psychological Association and a psychologist in private practice, I strongly support passage of this legislation. The practice of psychology is uniquely suited to telehealth, and longstanding research, as well as current anecdotal evidence from both Maine psychologists and from providers across the country, have clearly shown that for most populations, telehealth is just as effective as delivering services in person. In fact, I have found certain advantages to telehealth. Over the course of the pandemic, many of my clients have either moved or traveled out of state. Some states have created easily accessible temporary licenses that have allowed me to continue therapy with these clients. Unfortunately, other states did not, and there were many instances where I needed to terminate treatment. In a number of those cases, clients indicated that they would have kept meeting with me if that were an option, but that they were unlikely to unlikely to prioritize finding a new provider as they settled into their new locations. This lapse in coverage obviously has significant implications for the well-being, health, and safety of many Americans. As president of MEPA, I believe that SIPAC enhances our profession by eliminating many barriers to practice. As more and more states continue to adopt SIPAC, it's easier for out-of-state providers to relocate to Maine while maintaining their current practices. Allowing specialists the opportunity to move to Maine without surrendering their practice can help us attract more highly qualified professionals to the state. MEPA is regularly contacted by psychologists who've had to either postpone or cancel plans to Maine because of the difficulties with obtaining a license. Increased access to interjurisdictional practice can significantly alleviate this bottleneck. Finally, and most importantly, enacting SIPAC has dramatic benefits for the people of Maine. The increased demands for services during the pandemic has highlighted the extent to which there are not enough psychologists in the state to meet the needs of many Mainers. I continue to field phone calls in my practice from prospective clients, hospitals, schools, and primary care settings that are unable to find behavioral health providers for people in need. Access to out-of-state providers will help reduce the burden on Maine psychologists.
Mr. Cooper, can you wrap it up for me?
Yes, of course. One last point is that this will also increase access to out-of-state specialists for at-risk populations, especially those with opioid use disorder, autism spectrum disorder, as well as children and veterans. Thank you very much.
Thank you. Are there questions? All right, seeing none, we thank you for Representative Arford.
Yeah.
Go ahead.
Question. We had a discussion earlier with Commissioner Head regarding how rules would be developed and passed in our state for the various professional boards. And I'm assuming that will happen here in Maine for the psychologist board. Or however, I'm not, will those rules, the way in which they have been developed here in Maine, will they be in any way impacted by this compact?
My understanding is that within a SIPAC practice, the rules of SIPAC trump the actual state practice. However, I would like to point out that the discrepancy between rules is often very, very minimal, and that SIPAC has been written with this concern in mind, so that the requirements for licensure are consistent with what states are looking for.
Is there any public process that, so the public is able to participate in the development of the rules for the SIPAC? Is the public into that rulemaking?
That is a fantastic question. Ms. Safford could answer that better than I, but I will be sure to follow up with that.
Thank you.
Representative Matheson.
Yes, thank you, Madam Chair. I'm wondering if SIPAC allows us to retain the board's ability to create licensing by endorsements for immigrants.
So the board would still have absolute ability for licensure for providers within the state. And SIPAC legislation would only apply to treatments that are being provided within interjurisdictional practice.
Representative Evans.
Thank you, Madam Chair. Two questions. One, I'm assuming that there is no conflict between your organization and the American Psychological Association.
That is correct.
Okay. And two, the liability of a SIPAC member resides within the state where the psychologist is licensed.
Licensed and practicing, correct.
And practicing. Okay, thank you.
Are there any other questions for Mr. Cooper? Seeing none, the next person we'll hear from is Christopher Arnold. Mr. Arnold seems to be having a very long wormhole experience. Hopefully we'll see him soon. There he is. Welcome, Mr. Arnold. You can unmute yourself and start your video for us.
Thank you, Madam Chair, Madam Co-Chair, honorable committee members. The Department of Defense expresses its support for the policy changes proposed in Maine Bill 863, the Psychology Interjurisdictional Compact, more commonly known as SIPAC, which addresses licensing issues affecting our service members and their families. I would like to thank you for considering this issue in the 2021 session. My name is Christopher Arnold. I am the Northeast Region Liaison at the United States Department of Defense State Liaison Office, operating under the direction of the Undersecretary of Defense for Personnel and Readiness. Licensure issues for both our transitioning military members and their spouses have been a priority for the department for several years. The issue is so important the Secretary of Defense has made taking care of our service members and their families a fourth line of effort in our national defense strategy. The secretaries of the military departments have made the importance of military spouse licensure explicitly clear as they consider the availability of license reciprocity when evaluating future basing or mission alternatives. As you likely saw in my written testimony, this has been expressed by the Air Force in an annual installation level scorecard, which pursuant to the 2020 National Defense Authorization Act in addition to evaluating Bangor National Air Guard Base, will soon be done by the Department of the Navy for the shipyard in Kittery. The Air Force's scorecard evaluates 9 occupations, including psychology. To address license portability for military spouses, states have turned to occupational licensure interstate compacts, which streamline relicensing between member states of a compact for all practitioners in an occupation and provide specific support for military spouses of relocating active duty personnel through provisions recognizing unique requirements of military life. Occupational licensure compacts provide consistent rules for licensed members to work in other states. Common misinformation about compacts is that they either lower or raise the standards for the occupation, when in fact, compact states have the option to issue a compact license and also a state-only license to maintain your state's standards. The short duration of military assignments, coupled with lengthy relicensing processes, can discourage military spouses from seeking relicensure, causing them to quit an occupation or causing military families to leave the military. Complicating matters further, the term reciprocity is used differently among states. Therefore, states have committed to using interstate compacts, which establish common understanding of competency and its measurements within an occupation to resolve the interstate issue of license portability. Approved in February 2015 by the Association of State and Provincial Psychology Boards Board of Directors, SIPACT has been created to facilitate telehealth and temporary in-person face-to-face practice of psychology across jurisdictional boundaries. Under SIPACT, a psychologist can obtain an e-passport to practice telepsychology and or conduct temporary in-person face-to-face practice. A doctoral degree in psychology is required to obtain the e-passport. SIPACT is of dual benefit in that it not only expands access to care for military service members, but also allows military spouses who are practicing psychologists to conduct interstate practice via telehealth or in person. Portable employment opportunities support military spouse career development. SIPACT allows an active duty service member or their spouse to designate a home state where the individual has a current license in good standing. This state then serves as the individual's home state for as long as the service member is on active duty while adhering to the laws, rules, and scope of practice in Maine. The Department of Defense encourages states to engage in immediate actions to fully implement military spouse licensure laws, near-term actions to attain at least a baseline of getting a military spouse a license within 30 days based on minimal documentation, as seen in Bill 374 from Senator Curry and Commissioner Head, and long-term solutions for reciprocity through compacts such as this bill and in the Occupational Therapy Compact, Bill number 31, sponsored by Senator Sanborn, which the department hopes will be passed later in the session.
Can you wrap it up for me, Mr. Arnold? The 3 minutes has expired.
Opportunity to support the passage of the bill.
Great. Thank you very much. Are there any questions for Mr. Arnold? All right, seeing none, we thank you for joining us today and giving that additional perspective. Next, I would ask if there's anyone else who wishes to testify in favor of the bill. Seeing none, I'll ask if there's anyone in our Zoom meeting who intended to testify in opposition to the bill. Seeing none, we'll go to those who are registered to speak neither for nor against, and we'll start with Ms. Halverson. Go ahead, Ms. Halverson.
Thank you. I just wanted to clear up one thing too. I'm also the administrator for the Board of Examiners of Psychologists as well as counseling.
Got it.
Thank you, Senator Sanborn, Representative Tepler, and members of the committee. I am Christina Halverson, administrator for the Board of Examiners of Psychologists within the Office of Professional and Occupational Regulation. I am here today to testify neither for nor against LD 863, which proposes that Maine join SIPACT. I have also submitted written testimony with additional information I won't go through right now. The Office of Professional and Occupational Regulation and the board are acutely aware of the shortage of mental health providers in Maine and around the country, and we are committed to thoughtful efforts to increase access to high quality care. This session, we worked with Representative Kristen Cloutier to introduce LD 149, which establishes a licensure by endorsement application process for U.S. license holders who wish to obtain a Maine license. This endorsement process strikes a balance between allowing Maine's boards to serve their public protection mission while also expanding the workforce to serve Maine citizens. While we are supportive of facilitating Maine licensure and expanding the workforce, the board has some lingering questions about the implementation of the compact. For one, it is important to note that states wishing to join the compact must adopt the model language. This is a contract that the states are mutually bound to, and there's no ability to modify or tailor it to a particular state. And states are similarly bound to all rules promulgated by the SIPAC Commission. A concrete example of how that might affect Maine is the requirement to report significant investigatory information to the Commission to make it available to other compact states, which is in conflict with Maine's statute, providing that all complaints and investigatory information remain confidential until the complaint is finally resolved. Moreover, it's important to note that SIPAC, while developed many years ago, only became active in April 2019 when Georgia signed on as the 7th state to enact SIPAC. The first commission meeting took place in the summer of 2019. As such, many of the details are still being worked out, as was evident at the SIPAC Commission's November 2020 meeting, where a member state asked if a psychologist providing telepsychology services into another compact state was subject to the scope of practice of that state, and which laws and rules apply to that psychologist. Would it be the home state or the receiving state's laws? What happens if there is a conflict of laws? No clear answer emerged from the governing documents, and the SIPAC Rules Committee took the matter under review. Lastly, there is a cost associated to the board with participating, $10 per psychologist holding a SIPAC privilege in Maine with a maximum cap of $6,000 annually. The board does not receive any revenue from any privilege granted to SIPAC practitioners and may need to consider raising licensing fees to cover this cost. I thank you for your attention, and I am happy to answer your questions now or at the work session.
Thank you, Ms. Halverson. Pardon me. Thank you, Ms. Halverson. The information with regard to scope of practice and what applies, the information you gave us seems at odds with what we heard from the folks who testified earlier, including gentlemen from the DOD. And so I'm curious whether it was that at that meeting it was confused, or there was sort of confusing discussion about it, or whether the compact itself is truly silent on the matter. It seems like a foundational question that a compact would answer.
It is. And what happened yesterday, we listened to the Rules Committee meeting for SIPAC yesterday afternoon, where this was brought up again. They are going to try to draft some language to address this and bring it back to the Rules Committee, because there was no clear answer yesterday. They'll bring it back to the Rules Committee at the next Rules Committee meeting. So that is just one of the questions. For instance, our state law allows a psychologist to provide services to minors for substance abuse without having, they're not under any obligation to obtain the consent of the parent or the guardian for that. If someone is sitting in their home state, another state, and providing those services into Maine, and their home state says they have to get that permission, how does that affect the services provided into Maine? That would be a conflict. And that's the question that needs to be answered. The OPOR attorney and I are gathering that information and hope to have all that by the work session for you.
Okay, certainly. I mean, my concern would be to ensure that conversion therapy wasn't being conducted, if that were permitted to be done by licensed professionals in the home state on youth in Maine, because that's illegal in Maine. So, I have concerns about this. I just want to make sure that we're not making up concerns that are actually dealt with by the compact, because those seem like very straightforward, resolution that the compact would have addressed in its text itself, not just in its rules. But maybe the issue of age of consent is slightly different than some other rules, like scope of practice or that type of thing. So it would be helpful to understand what's really unresolved here, because it seems that the home state, or sorry, the state of the patient would be the one that governs, which is what we heard from the other 3 folks who testified.
Would it be helpful if we forwarded to your analyst the actual bylaws, rules, and a legal opinion from SIPAC?
Yes, that would be
Okay.
very helpful. So we could understand exactly what's sort of up in the air and what needs to be resolved still. Because I do understand this is a relatively new compact. I think a number of them are pretty new in the different licensing boards that we're going to be going through. I know we have at least one more to do this year.
Okay,
Are there
I'll get
additional?
that.
Thanks. Are there additional questions for Ms. Halverson? All right, not seeing any. We thank you for joining us today and look forward to working with you more on this issue. Thanks.
Thank you very much.
Next, we'll hear from Louis Levy from Teladoc.
I do not see Louis Levy on the call.
Oh, okay. We'll bring over Bruce Garrity. Good afternoon, Mr. Garrity. Go ahead.
Good afternoon, Senator, and thank you. Senator Sanborn, Representative Tepler, and members of the committee. My name is Bruce Garrity. I'm testifying this afternoon on behalf of Teladoc and on behalf of the Maine Automobile Dealers Association. I won't comment on the background of those 2 clients as we've already done so. I will advise that Dr. Levy was unable to stay on the call, so he will not be testifying on other bills he was listed for this afternoon, but I will be. Very, very briefly, we actually support Representative Tepler's bill. We think the compact is a good idea. The only reason we're testifying as neither is because we do realize that there is an overlap or an impact on a potential impact on state rules. And while we don't take a position on which is preferred, we leave that to the committee's decision, but we generally, that point aside, are in support of the bill. And I'd be happy to try and answer any questions the committee might have, Senator.
Thank you, Mr. Garrity. I'm a little puzzled by the why the neither piece, but I understand sometimes why like the Bureau would not want to tell us what the policy should be because we're the legislature, but I'm a little puzzled as to why Teladoc or your other clients wouldn't want to tell us what the policy should be.
Well, and as you know, Senator, I generally, and my clients are not bashful in letting the committee know what our thoughts are. And I think I did mention, if I didn't, let me clarify that we are supportive of the bill. But we did think, we didn't know what the other testimony would be. We haven't reviewed the bill, the compact in such detail as to feel 100% comfortable in testifying in support, just knowing that there would be input from the psychological profession. And so we thought this was the more appropriate place to start. If the committee is comfortable with this approach of the compact, we certainly will be.
Okay, I just wanted to make sure there wasn't a red flag of some sort in the rules that we were missing, because that's what we're trying to figure out in order to understand if we should be comfortable. But you don't know of one.
I do not know of one.
Okay, great. Thank you for joining us. Are there any other questions for Mr. Garrity? Representative Arford, did you want to ask a question? You unmuted.
Again, aware of our time constraints today, but just very quickly in this, this question I should have potentially asked it of an earlier person, and I apologize for not doing that. You may not be able to answer this, Mr. Garrity, but one of the things that I just realized, we haven't been speaking about how this is going to impact the cost of services that are delivered through this compact. And I understand that that's not part of specifically of this bill. However, if you have a psychologist who is accustomed to, who lives and practices in New York City and is paid X amount for his services through his insurance, and compared to someone who lives and has lived and worked in Maine and is paid X amount, there could be a significant discrepancy. And I'm just wondering, will the compact, is the compact designed to negotiate rates for the people that work through them in any way? Or when you have a discrepancy in the rates between your home state and the state you're delivering services in, how is that addressed?
I have to say, I think that's a great question. I think it's an important question for the committee, and I do not know the answer. I will try to get you an answer on that by the time of the work session, Representative.
Thank you.
I do think it's a question perhaps even for a later hearing this afternoon. We're going to have a whole section on reimbursement rates. Okay. Are there any other questions for Mr. Garrity? All right, seeing none, that is the end of my list of folks who had signed up to testify in this hearing. And I'll ask if there's anyone else in our Zoom meeting who had intended to testify in this bill, LD 863 today. Seeing no electronic hands being raised, I'll close the hearing on LD 863. The next grouping of bills that we are going to pick up is one that I have called bills related to licensing of out-of-state providers. So it's sort of related to the SIPAC bill, but much broader and more general in that it covers many more areas of licensure. And so those two bills are LD 1194, sponsored by Representative Libby, and LD 1361, sponsored by Senator Stewart, who I think Representative Morris is going to stand in for because Senator Stewart hasn't been able to join us yet. So first we'll hear from Representative Libby. Thank you for joining us again. I know you have a busy day over in the Judiciary Committee, so thank you for joining us, and you can go ahead.
Thank you so much. And actually this hit perfectly. We're on break. So
oh, good.
Perfect timing. So thank you so much. I will not reiterate all of my testimony. Some of this testimony is very similar to my previous, but I'll get started here. Senator Sanborn, Representative Tepler, and distinguished members of the Committee on Health Coverage, Insurance, and Financial Services. My name is Laurel Libby, and I represent House District 64. I come before you today to present LD 1194, an act to reduce healthcare worker shortages. This bill makes permanent the authorization for licensing out-of-state and recently retired doctors, physician assistants, and nurses that was provided through executive order during the declared state of civil emergency related to COVID-19 and is ongoing. The bill also expands the scope of healthcare services that can be provided through telehealth to include the use of audio-only telephone. Let's see, let me skip ahead to parts that I didn't share in the previous hearing. So on March 20th, 2020, Governor Mills relaxed regulations relating to licensing and telehealth in Executive Order number 16. Throughout COVID, this has enabled healthcare providers an expanded ability to provide healthcare services to Maine citizens. Here in Maine, we chronically face a healthcare provider shortage. Every facility in which I've ever worked has utilized travel nurses to fill these gaps, and I myself worked as a travel nurse in Detroit for a summer. The ease of obtaining a license comes into play at times when staff are considering their next travel assignment. Under Governor Mills' Emergency Order number 16, healthcare providers in good standing that are licensed in another state can be issued a Maine license to practice very rapidly, reducing the waiting period from 45 to 90 days down to 48 hours. I do have an amendment that I would like to request that I had discussed with one of my co-sponsors, Representative Evans, and that would strike the sections related to supervision or collaborative practice agreement suspensions, as your committee has already addressed this issue this session and done good work on that issue. So I don't want to reinvent the wheel here. Maine's healthcare provider shortage existed long before COVID. Now we have learned that we have the capability to expedite the licensing process, and we should reduce the shortage by removing obstacles to licensure, including their expensive price tags. These reforms will give Maine a competitive edge in recruitment for the healthcare professionals that we so desperately need. In regards to the telehealth expansion, specifically the telephonic telehealth, I'd like to read to you what a constituent shared with me. My baby has a rare genetic condition that affects only 1 in 32,000 people. Only 2 hospitals in the entire United States research it. Before telehealth became readily available because of COVID, he spent 80% of his life admitted to hospitals when traveling to distant appointments. Travel canceled because of extreme weather has had severe consequences for my son. Now, with telehealth, we can go to the local hospital for labs and imaging, and the results are sent to the specialist. The specialist is then able to diagnose and discuss concerns via Zoom or telephone. We need this. We need faster answers and a decent quality of life for our son, who already has to fight harder. This is one of those lemons of COVID that has really become lemonade for this constituent because their quality of care has gone up so much higher since COVID because of the changes in telehealth. So if these changes can be done safely during a national health crisis, why can't we do them during stable times? We should remove these regulations permanently and safely ease the red tape around licensure and telehealth so that Maine people can access the care that they need. I would like to thank Senator Claxton and Representatives Evans, Geiger, Perry, and White for co-sponsoring this bill, and this committee for your time and consideration, and I'd be happy to answer any questions that you may have.
Thank you, Representative Libby. Are there questions for Representative Libby? All right, seeing none, we thank you for joining us again. And I'm glad that we coincided with your lunch break in our other committee.
Hopefully you guys can too. Thank you.
All right, bye. Next we will hear from Representative Morris on behalf of Senator Stewart.
Yes, thank you, Madam Chair. There they go.
It happens here too, I understand.
Clockwork. All right. All right. Senator Sanborn, Representative Tepler, and esteemed members of the Committee on Health Coverage, Insurance, and Financial Services. I am not Trey Stewart, but I am presenting his bill today. I'm here today to present testimony on LD 1361, an act to amend telehealth laws regarding out-of-state telehealth provisions. The legislation before you is aimed at making access to telehealth easier for patients and providers alike. To do so, it amends the definition of telehealth and broadens it to include audio-only telephone, facsimile machine, email, and texting. All right. Serving on this committee, as well as Energy, Utilities, and Technology Committee, I am keenly aware of the barriers Mainers face at accessing good internet and healthcare. Despite having hearings online via Zoom, I know a few legislators that continue to drive to Augusta every day because their internet cannot handle real-time visual means of communication such as Zoom or Microsoft Teams. Additionally, with an aging population, the new learning curve to modern day technology is a barrier. One of the key reasons telehealth is important is because it allows people to connect with a physician from the comfort of their own home without having to drive or have someone drive them a far distance. I believe by adding these other methods for telehealth providers and patients to connect will make it easier for our elderly and those living in rural Maine to access telehealth. While they may not be able to navigate a meeting over Zoom or Teams, they certainly know how to use a phone. The bill also provides the practicing physicians with an unrestricted license in other states may practice telehealth in Maine without being registered in the state of Maine. For individuals needing a consultation visit with a specialist out of state before a procedure, this provision will make it easier and eliminate the geographical barrier to quality health care. This will make it easier for disabled and elderly patients who already struggle to make it to a traditional inpatient visit. While telehealth has been around for years, the COVID-19 pandemic has made it even clearer that greater access to healthcare is important. By reducing the current barriers to telehealth, as is suggested in this legislation, we will be able to accomplish that goal for rural, disabled, and elderly Mainers. Thank you for your time and consideration of this important piece of legislation.
Thank you, Representative Morris. Are there questions? Well, Representative Morris isn't actually the sponsor, so I guess I won't give him the chance to try and answer questions from you all. So we are going to combine the lists of folks who had registered in advance to testify in favor of LD 1194 and 1361. So I will make my way through those lists and call on Mr. Garrity to come back and join us.
Good afternoon.
Good afternoon. Go ahead.
Thank you. Senator Sanborn, Representative Tepler, members of the committee. My name is Bruce Garrity, and I'm again testifying on behalf of both Teladoc and the Maine Automobile Dealers Association. We're testifying in a different category on each of the bills. We're testifying as neither for nor against on Representative Libby's bill because, in our view, while it advances the ball, so to speak, by including telephonic care, it excludes fax, email, and texting. And we believe, for the reasons you've heard in relation to other bills, that that is an appropriate step to take. In addition, while we appreciate Representative Libby's suggestion that there should be an immediate licensing requirement, or process, I should say, we are concerned that we think it's more appropriate to base activity in telemedicine on whether someone is licensed in their own state. At most, a registration process. We're not sure even that is necessary given the global nature of healthcare. With respect to LD 1361, I owe Senator Stewart an apology. He put that bill in at my request, and we did have some snafus with the drafting of the bill. It does not say that it includes the ability of an individual licensed in another jurisdiction to work with a patient in the state of Maine. The summary has that language in it and specifically says that it allows a telehealth provider in one location and an enrollee in another location, either directly or through another healthcare provider. We believe that this broadened ability is crucial. It gives an individual more control over whom they go see, when they go see them, assuming that they have started with someone more local, understand the nature of their issue, and want to consult with someone they might think is the world expert or an acknowledged expert in the field beyond the borders of Maine. So that's a key provision in the bill to us. We most certainly support his language that removes telephone, facsimile, and email or texting as exclusions from telemedicine. And Senator Sanborn, I'd be happy to try and answer any questions the committee might have. I know you have a long day. You don't need to hear me go on.
We do, although we're actually moving through it relatively quickly, Mr. Garrity, so I appreciate your deference, but I'm puzzled and confused. So it would be helpful to know, I'm guessing maybe the rest of the committee is too. You apologized for a drafting error. I don't understand what is in the bill and what was intended to be in the bill. And I think you're talking about Senator Stewart's bill. So what is missing from Senator Stewart's bill?
I don't think it clearly says that an individual, a practitioner licensed in another state, can directly interact with an individual patient or enrollee in this state without anyone else participating. If it does say that, then I'm misreading it the other way, but I don't think it is clear. If you look at the language, it references on page 1, lines 21 and 22, the category of licensed individual consulting through telehealth. It says that an individual, in this case osteopathic, may engage in consultation through telehealth with an individual licensed to practice in another state without being licensed under this chapter. That sounds to us like it was intended to say you can directly consult as an enrollee with a practitioner in another state. It's not clear to me that that language does that. Then when you go down to page 1, lines 34 and 35, it again references an individual in another state, again, who holds a license, may engage in consultation with an individual licensed to practice. Now, I get that this is a different section as part of a different statute, but both seem to be limited to consultations with licensed individuals in Maine, as opposed to also including the ability to work directly with an enrollee in the state of Maine, which is the intent and goal of the legislation. And I think that point's been made in relation to other bills, Senator, but that's where we think the snafu is in comparison to the summary, which accurately stated what was supposed to be in the bill.
Okay, so I think I understand now what you intended to be in the bill, so that's helpful. Thank you. But now I'm a little bit puzzled because I think if that is what the bill was intended to do, then doesn't that just cede our licensing entirely? We don't need to pass SIPAC because you don't need a license to provide telehealth in Maine, period, full stop. If we were to pass the bill as you intended it to be drafted, is that right?
I don't think exactly. SIPAC deals, as I understand it, with psychological issues. This legislation is more broad in scope in terms of dealing with practitioners outside the scope of the compact that you had discussed.
Okay, let me reframe the question, Mr. Garrity, because I didn't mean it to be about which type of practitioner we were talking about. I just meant to say that with regard to telehealth, we would just throw open the doors and you can treat anyone in Maine with just any license in any other state. And we wouldn't have any authority over you for the unlicensed practice of medicine as long as you're doing it through telehealth. Is that the intention of the bill as you meant it to be drafted?
Close, but not exactly, because we do think that there need to be provisions where if an individual has a license issue in another state, if it's been suspended, if they've had some sort of a problem, that would prohibit them from practicing in Maine, or at least require a review by the appropriate board. I think if the committee wants to go beyond that to a registration type of standard, that might be an interim approach you could look at. We certainly don't think full board licensure is necessary. Again, recognizing that pretty much every state, as far as I know, every state has licensing criteria for individuals, whether they are a physician, an osteopath, an optometrist, a podiatrist, the various categories that were in Governor Mills's legislation.
Right. But so let me walk this out again, though. With this exemption in place as drafted, there wouldn't be any moment at which anyone checked whether your license was in good standing in another state or whether you were under investigation for any number of terrible things that I could name off but won't. There wouldn't be any license review at all because there's no need to have a license in the state of Maine. As long as you still have an unrestricted license in another state, you could get on telehealth and do whatever. Is that was your intent?
Yeah, I think that's true.
Okay. And so then my other question is about what rules, what governs the scope of practice and the treatment standards of the doctor when they're providing health and telehealth services to someone who is physically present in the state of Maine when they're receiving their services. Is it the standards of Maine, or is it the standards of the home state?
It would be the domiciliary state.
Okay, so if conversion therapy on minors is permitted under to be conducted by a doctor in another state, and then they do it by telehealth in the state of Maine, that would be legal after we pass this bill?
You passed it like that. If you wanted to go in a different direction, what you would have to do is tie care in Maine to Maine's rules so that the individual doing the practicing would understand that whatever limitations exist in Maine, they would have to comply with.
And then
isn't
if
part
that
of what's drafted, but that would be
okay,
one way to address it.
and if that person who's providing those that care violates those rules but doesn't have a Maine license because they're not required to, how would we enforce those rules, such as the conversion therapy ban, which the enforcement mechanism is to take away your license, but they're not licensed in Maine. So how would we enforce that?
Well, I think there are two answers to that. The first is that if you were to require that the practitioner adhere to the rules of Maine, that sets up your licensing board authority in that kind of situation. And second, just as these licensing boards rely on complaints from people in the state of Maine, they would continue to rely on complaints from people in the state of Maine. Otherwise, if we think about it, let's assume someone does something that violates the standard of care in Maine and they're a Maine practitioner. If no one complains, I'm not saying this is a good thing, but if no one complains, no one knows. The complaint is what starts the process, be it a complaint from a patient or a complaint from another physician who comes to understand something has happened that isn't appropriate. So that would be the same process.
Sure, but if it's a complaint that's not against a licensee, then the licensee doesn't, then the provider isn't subject to the Board of Licensure. We'd have to refer them to the Attorney General for unlicensed practice of medicine, except you've just said that we don't need a license for the practice of medicine. So I'm a bit baffled as to how this would work in practice, but I'll give you a chance for the last word on that, and then I'll move on.
I never feel like I get the last word, Senator. But on that, to the extent that you place a requirement on a licensee anywhere that they have to play by the rules of the game in Maine, and you make them subject to those rules, I don't think it would be very difficult at all to extend jurisdiction of the board to an individual in that, a practitioner in that situation.
Okay. Representative Tepler.
Thank you, Madam Chair, and thank you for being here again, Mr. Garrity. Mr. Garrity, can you briefly explain why you want to include remote monitoring as a part of telehealth?
To the extent that an individual is working with an out-of-state practitioner, there are, and I'm not sure what they are, but there are monitoring processes where the physician or the practitioner remotely becomes aware of what's going on with the patient's health. And just as using fax or using email or using telephone are ways to work with a patient, becoming aware that something is off in some sort of a monitoring context does the same thing.
Okay, I guess I don't feel that there's anything in current law that prohibits a person who is being monitored by a physician from traveling. But
okay.
No,
yeah.
but let me respond if I could, and I appreciate I appreciate your thought on that. To the extent that you think it's appropriate to give a temporary license or registration, some process pursuant to which you feel the board has more control over someone who's out of state, and several bills certainly go in that direction. That individual, that practitioner, would then have the ability to do whatever remote monitoring might be involved, I think. Does it matter as a matter of either public policy or as a matter of good medical care if you have a professional in Portland monitoring someone in Presque Isle for some sort of condition versus having a practitioner in Portsmouth or Boston or wherever doing that monitoring, to the extent that they're helping to provide care? I don't see a difference there in terms of the efficacy of using monitoring.
Okay, thank you, Mr. Garrity, and thanks for allowing me to run down the rabbit hole there and get some clarity around what was intended on that bill. I think I've reached the end of the list of folks who had intended to testify in favor of the bill. So if folks that are in the participant area could put their hands down, and then thanks. And then if you had intended to testify in favor of either of these two bills, if you could raise your electronic hand now, that would be great. Okay, we'll bring over Dr. Dixon. Good afternoon, Dr. Dixon. Go ahead.
Thank you. I came back over, I hadn't intended to speak here, but I came back over to hopefully to provide some light on some things that have been said here recently. One of the things that I talked about when I was here before is that main care reimbursement rates are important if you're looking to get services for people who are covered by main care and you're working, you want to work in states through telehealth, in states that have a lot higher reimbursement. So this is a graphic that I prepared and I just sent to the committee. So I'm hoping you can see that graphic. It compares Medicaid rates for states in the area, Northern New England and Massachusetts. And the effect of 592 would have been would be to raise those rates. And there are a lot
Mr. Dixon, are you testifying in support of the two bills we're hearing right now, which are about how to deal with folks providing telehealth about licensing?
Well, I know there was concern even in this section about, well, whose rates would apply? And this address tries to address that question.
Okay. Definitely understand
and yes,
that.
It also would apply to 863, admittedly, but
okay,
it would apply there. And I will also tell you that when I testified in front of DHHS or HHS committee, they decided to ask their OPLA analysts to get rates for other types of people who deliver therapy and counseling, including LCPCs and social workers. So those may be rattling around in the system comparative, but those will all apply to people who are delivering through telehealth services to under either these two bills or the 863. I appreciated your confusion, Madam Chair, Madam Sanborn, because I was very confused listening to the last person testifying, and I've already said, I think we should maintain tight controls, and I understand that you have concerns about how H63 would, but saying anybody that has a license anywhere can deliver telehealth does not seem like a good idea. I'm going to leave now. I will see you later. And I hope I've been helpful and haven't interfered with your process. Thank you.
Okay. No, you have not interfered at all. We are going to be taking up some bills that more specifically talk about insurance reimbursement in the next section, the last section of our hearings today. Okay. So with that, I will turn to those who wish to testify in opposition to one or both of these two bills. And I'm going to call on Timothy Terranova, who's hopefully with us. I'm not looking at the participant list. Good afternoon, Mr. Terranova. Go ahead.
Good afternoon. Thank you, Senator Sanborn, Representative Tepler, and members of the committee. My name is Tim Terranova, and I am the Assistant Executive Director for the Board of Licensure in Medicine. You have my written testimony in opposition to LD 1194 and 1361. I will not read it, but I would like to draw your attention to some issues. First and foremost, the board recognizes the importance of telemedicine and its benefits. Licensees of the board have been using telemedicine to provide care to Maine patients for years. Second, telemedicine is not a specialty. It's a delivery model. It's how that care is provided. Approximately half of the board's licensees are located outside of the state. Many of those provide healthcare through telemedicine. The board has a robust and efficient licensing process. We also belong to the Interstate Medical Licensure Compact, and through that compact, we issue licenses within 72 hours. The current system works. Our major concern with these bills is, as was mentioned in the previous testimony, we do not, if they are not licensed, we do not have jurisdiction over these practitioners. You heard this morning from Dr. Chu some examples of care that had gone wrong. Maine patients would not have any recourse through Maine, through the state of Maine, in those situations if those people were not licensed by Maine. So that is our main concern. I can't stress that enough, and I will leave my testimony there, and I'm happy to answer any questions.
Thank you, Mr. Terranova. Are there any questions for Mr. Terranova? Okay, I see none. So we thank you for joining us. We can send both Mr. Terranova and Mr. Dixon back through the wormhole, Christian. And next person I'm going to call in opposition to the bills is Dan Moran. Good afternoon, Mr. Moran. Go ahead.
Hi, thank you, Chair Sanborn, Chair Tepler, members of the committee. My name is Dan Moran, Director of Communications and Government Affairs, and I'm here on behalf of the Maine Medical Association located in Manchester, representing more than 4,300 physicians, residents, and medical students across all clinical specialties, organizations, and practice settings. We're submitting testimony in opposition to portions of 3 bills, including the 2 before you right now and one coming up later. So prior to the COVID-19 pandemic, this is unnecessary, first off, these parts of these bills regarding out-of-state licensure. Prior to the COVID-19 pandemic, a major force in supporting telehealth expansion was the Interstate Medical Licensure Compact. It's designed to preserve state regulation of medical practice while making it easier for physicians to provide care remotely and sometimes in other states. According to the American Medical Association, the compact has grown by 47% during the pandemic, even as most states and CMS, a federal agency, temporarily waived the requirement for specific licensure. Physicians are taking advantage of the existing process. It's already happening even before the pandemic. Louisiana became the 32nd member in October of the compact, joining 29 other states, Guam and the District of Columbia, and 8 other states have legislation right now to be members of the compact. That would take it up to 40 entities. Existing board law with the osteopathic and the allopathic board already includes licensure by reciprocity. Colleen can find that, section 3275 for physicians, and also covers situations referenced before by some proponents, allowing the registration for physicians in any other state with Maine's licensing boards for providing consultative services. That's section 3300-D. Physician licensing boards have an imposing duty to grant licenses to individuals with a mission of protecting the public health, safety, and welfare. They take a look at practice acts in other states, our practice act, review administrative regulations. They look to national standards of practice and authority granted by you, the legislature, which you've already given for a lot of the supposed problems that you're hearing. The board's mission is to protect Maine citizens, not to allow multi-billion-dollar for-profit telehealth companies to invade Maine and for out-of-state physicians to save $500 or $600 getting registered to provide consultative services or get a Maine license. And finally, as Mr. Terranova said, this could decimate the operations of our physician licensing boards, as over half of the licensees currently with the Board of Licensure in Medicine are currently out of state. Get a license, approach the board. And in my testimony that I've uploaded, although albeit late, it shows you in one mouse click, a physician can go to the Interstate Medical Licensure Compact and apply for a license right now. Thank you.
Thank you, Mr. Moran. Are there questions for Mr. Moran? Representative Tepler.
Thank you, Madam Chair. Thank you for being here, Mr. Moran. I kind of want to go back to the question I asked the previous person giving testimony. Is there any barrier to a physician who is out of state right now doing remote monitoring of a patient who travels to Maine?
You know, I want to get a specific answer for you between that and the work session, because we have heard from members, you know, snowbirds that go down to Florida. There are questions and some uncertainty among licensees for, you know, my aunt and uncle, for example, who have primary care physicians here and specialists that go down to Florida. What can their clinicians do up here, down there when they're there? Right. So I don't want to give you an answer, Representative Tepler. I have never done this. I don't want to give you an answer and make an assumption. I want to get you factual responses, and I will do that.
Thank you.
I think I now understand the telemonitoring question that I didn't understand before. So thank you for asking it again, Representative Tepler. All right, so next we will hear from Herbert Cushing. Good afternoon, Mr. Cushing. You can go ahead.
Good afternoon. Senator Sanborn, Representative Tepler. I'm Dr. Herb Cushing, Spectrum Chief Medical Officer. Thank you for hearing me today. I'm in opposition in Spectrum Healthcare Partners, where I serve as CMO, is in opposition to 1194 and 1361. We strongly support telemedicine. The principles are fine, as Dan just pointed out. We've been doing it for years. I have been doing it for years.
Mr. Cushing, I'm having trouble hearing you. Can you speak a little bit more loudly or closer to your computer?
It looks weird, but I'll be very close. Can you hear me now?
That's better. Yes, thank you.
Yeah, thanks. Sorry about the bad mic. But we, Spectrum is in strong support of telehealth and all of the principles that engenders. That's not the issue. But I strongly believe that we need to completely license all the physicians that participate in it. It's not it is occasional in my career that I have found physicians from out of state that need to do work for us who are licensed in other states. When we completely vet them through the state licensing board or through the hospital boards, that we find issues that make them unfit for service. It's easy to get licensed in states and stay licensed, and sometimes they miss things or overlook things because of politics that are local that we would find unacceptable to provide care in Maine. So I strongly support continued full licensure, as the other folks have commented. And I'll be happy to take questions.
Are there any questions for Mr. Cushing? Seeing none, we thank Representative Arford. Go ahead.
Again, just quickly, I've been involved in nationwide patient safety network for many years. I'm not myself an expert, but I have a number of colleagues who are, and I have heard stories of physicians making very serious mistakes in their own state, then moving to another state, and there was no ability to communicate, and was able to get licensed in another state, and no way to trace this. I'm just wondering, is that one of your concerns, that people could be practicing, that our standards might be higher for licensing a physician than maybe the compacts, or that we would be more thorough in our vetting of a physician for licensure? What could you just a little bit, I want to make sure I'm understanding what you're saying, not what I may be thinking erroneously on this.
That's an excellent question, and it gets at the heart of the matter. The state licensing boards operate in a very similar way. They vet people very well, but you will see physicians get licensed in a state, and then things will happen after they have become licensed and they maintain their licensure in that state that perhaps don't rise to the level of the attention of their state licensing board or their local hospitals, but are discoverable when they apply for licensure in another state. And I don't want to give specific examples because they can be traceable back, but this happened to us happened to us with one of our teleradiologists recently. And then sometimes there are things that are overlooked by other state boards or hospital boards that we might find of concern. So yes, there may be slightly different standards across the states, but I think the issue is that the events that happen during practice are more easily discoverable when you go through the complete initial process at a state or a hospital. That's the key element to ensure safety around the nation. If we could do this in one way across the nation and continuously monitor folks, that would be okay too. That would solve it, but there's not a process in place to do that.
Thank you.
Okay, thank you. Next, we will hear from Mary Tedesco Schneck. Good afternoon, Ms. Schneck. Are you here? Good afternoon, Ms. Schneck. If you can unmute yourself and
sorry
start
about
your
that.
video.
I did.
Okay.
Yep. Thank you. Thank you, Senator Sanborn. I'm really going to be providing testimony for the next set of legislation, but I just had a question, and I thought maybe there seemed to be some questions about what monitoring was, and I don't know if that was your question, but I could provide you with some information on that.
No, I think the question was more about whether there was any concern about the unlicensed practice of medicine if you had a patient who traveled while you were performing telemonitoring.
Okay, so you're aware of the capabilities. Yeah. Okay, that was I'll go back.
Yeah, the question was more about licensing.
Yeah, I'll go back to the rabbit hole. I just didn't know if that was a question. Sorry to take your time on that. Okay.
Okay. All right. So with that, I think we have reached the end of those who wished to testify in opposition to the bills. And next I have Catherine Pelletreau, neither for nor against.
Good afternoon, Senator Sanborn, Representative Tepler, members of the committee. My name is Catherine Pelletreau. I speak today for the Maine Association of Health Plans. My comments are limited to the expansion of audio-only telephonic care. These are the first two bills today that you've seen where that propose to expand applicability there. So I'm happy to make these comments now, or I'm happy to hold them for the next round. Either.
Why don't you hold them for the next round? Because all of the bills in the next round do the same thing. So this, there was some overlap, but I wanted to kind of try and focus on discrete elements as much as we could. And I think actually we've been fairly successful in doing that today. So we'll talk all about audio only and reimbursement in the next segment.
Very good.
Thank you very much, Ms. Pelletreau, for letting us know that and letting us push you off to the next section of the hearing. Is there anyone else who wishes to testify in this section of our day today, which is about out-of-state licensing? And please raise your electronic hand. Mr. Yardley, go ahead. Good afternoon, Mr. Yardley. Go ahead.
Thank you, Senator Sanborn, Representative Tepler, and members of the committee. I'm Ben Yardley, Senior Attorney at the Bureau. Superintendent Chapa is unable to be at the hearings for the rest of the afternoon. I just wanted to say that the prior testimony, I think, makes it clear that, and we're only testifying on LD 1194, makes it clear that this is mostly licensing issues, and so we're not taking a position on that bill. Be glad to answer any questions to the extent that I've added anything to the conversation.
Are there any questions for Mr. Yardley? All right, seeing none, we thank you for joining us, and we'll see you later. Next up, we have Seth Rabinowitz. Good afternoon, Mr. Rabinowitz. You can go ahead.
Good afternoon. I was going to offer testimony on specifically Section 4, Provision 4 of LD 1194. However, if I understand correctly, that has been amended by the bill sponsor and stricken from the bill.
I think that's right.
Okay. In that case, I choose not to testify today, and I appreciate the committee's time. Thank you.
Okay, great. Thank you. Is there anyone else who wishes to speak neither for nor against these two bills? All right, seeing no hands go up, I will ask if anyone else intended to speak in this section of the hearing at all. And seeing no hands go up, I'm going to close our part 3 of the hearing, and we'll move on to part 4, but I think we should take a brief break. We've been going for a couple of hours. So we will start part 4 at 2:15. All right, good afternoon, everyone. It is 2:17, and we will get started with the last of our 4 public hearings on telehealth this afternoon. And just navigating back to my list here. The last 4 bills that we will hear are all grouped because they similarly touch on the definition of telehealth, particularly as it relates to audio-only technology and insurance reimbursement, particularly as it relates to reimbursement parity. So those bills are LD 323, 333, 849, and 649. And so we're going to start by inviting the sponsors of each of those bills to present them to the committee. And then I'll do my best to combine the testimony lists for those 4 bills as well during our public hearing, and we'll proceed as we have been throughout the day. So first we'll hear from Representative Perry. Good afternoon, go ahead.
Good afternoon. My testimony says good morning. You've had as long a day as we've had. Good afternoon, Senator Sanborn, Representative Tepler, members of the Committee on Health and Coverage, Insurance and Financial Services. I'm Representative Ann Perry, and I represent 9 communities in Washington County. I'm here today to introduce LD 323, an act regarding insurance coverage for telehealth services. This bill seeks to continue as permanent the telehealth services that were expanded as a result of the COVID-19 pandemic. This bill amends the law that requires health insurance carriers to cover telehealth services to define healthcare services provided through telephone communication as telehealth services. This will require a carrier to cover healthcare services provided through telephone communication, regardless of whether or not other telehealth services are available. It also allows patients receiving main care health services to provide verbal, electronic, and written consent to telehealth and telemonitoring services. Telehealth, which has had limited use in rural areas of Maine, can make healthcare more accessible to those who do not have the means or ability to travel for services. Also, with the means for broadband that would allow for other telehealth services. The pandemic emergency rules have given telehealth, have allowed a broader use of telehealth services. And this had been a good test of the effectiveness of telehealth. And from what I have seen, the results justify its continued use. And thank you for your consideration.
Thank you, Representative Perry. Are there any questions for Representative Perry? All right, seeing none, we thank you for bringing us this bill. Next, we'll hear from Patty Hymanson. Representative Hymanson. Good afternoon. Welcome back to our committee, Representative Hymanson.
Thank you.
Go ahead.
Welcoming me, and thank you for all your hard work. Good day. See, I put day because I didn't know if it was going to be morning or afternoon. Senator Sanborn, Representative Tepler, and members of the Joint Committee on Health Coverage, Insurance, and Financial Services, I present to you LD 333, an act regarding telehealth. You'll hear a lot of enthusiasm today for maintaining the expansion of telemedicine the pandemic has afforded us, both in the provider and in the patient sectors. I share that enthusiasm, but I also share caution, and this bill reflects both of those. I want to thank the Maine Medical Association for working with me on this bill, the clinicians around the state who shared their experiences with me, and my own patients who left me with the idea that we needed telemedicine to help improve quality, improve access, and lower the cost of care for patients. Of these three metrics, improving quality, improving access, and lowering the cost, it is easy to see that telemedicine improves access, especially in a rural state. I had a patient with severe migraine who had to drive from Biddeford to my office in Portsmouth, even when she had migraine or when she could report to me that everything was going well. Because I knew her so well, both of these visits could have been handled via telemedicine if it were possible at the time. The other two metrics, which are to improve quality and to lower the cost of care for patients, need to be looked at more carefully over time and with attention. Otherwise, we could have poorer care, inequities, and even larger medical bills. This bill, LD 333, adds, quote, audio-only telephone to the definition of, quote, telehealth, but only after the provider determines that real-time visual with audio is not available, infeasible, or impractical. If the exam is not in person, audio-visual can be adequate, but audio only is not adequate unless there are barriers to better care. There is still real value to an in-person exam using all of the examiner's senses. A diagnosis is more complete, as is the building of a trusting relationship for the future. The in-person examination is the standard of care, and some states have laws that mandate a primary provider must physically examine the person at an interval, for example, at least 18 months before a telemedicine visit can be used. That is not in this bill, but I ask you to consider it. This bill provides for reimbursement through telehealth services on the same basis at which the carrier reimburses for a substantially similar service through in-person consultations. This bill establishes that telehealth is included in the deductible limits with other services with no separate deductible limit. Also, prescribing medication by telemedicine would be the same as if prescribed in person. In line 7 of page 2, I would ask that you consider amending the line by inserting, quote, as determined by the provider, end quote, after, quote, medically appropriate. If I leave you with only one message, it is that telemedicine needs to be a tool for the provider, not a tool for payer controls. This is very important. A dermatologist in York told me that she stopped using telemedicine to diagnose skin lesions because the lighting and contrast, inability to touch the skin, were impediments to her being able to make a diagnosis. The provider has to have discretion to stop the telemedicine visit and convert it to an inpatient exam, require an in-person exam, or judge that a telemedicine visit is the best option. Who pays for the telemedicine visit exam that the provider rightly converted? We talk about value-based care, but we still use fee-for-service payments. This bill, like most others, was submitted by cloture in December of 2020. Federal, state, payer, and private companies have had vigorous conversations about how to manage telemedicine after the public health emergency is over. Waiting for the dust to settle a little more before changing Maine law by carrying over the axe and bridging it with a resolve might help create better and more long-lasting statutes. I also want to mention that I was reading through the Teladoc prospectus, their annual report, and I noticed that none of the executive officers are trained as medical practitioners. And there are 13 board of directors. 2 of them are MDs, no other medical professionals, and only one of the MD sees patients in a clinical setting from time to time. Thank you for your attention and consideration of this important and transformational tool to bring better quality, access, and lower cost to healthcare so that Mainers can be their best and healthiest selves. I'm happy to answer questions as I'm able, and I plan to be at the work session. Thank you.
Thank you, Representative Hymanson. Representative Quint, go ahead.
Thank you. And thank you, Representative Hymanson. Many of the brought up have been some of the questions that I've been asking all along, where I've been uncomfortable where telemedicine becomes the primary source of care, especially in rural areas. So I like the idea of having an actual in-person visit. My question is, when you were speaking about the client that you knew well enough that a telephone call would have sufficed, would you feel as comfortable doing that with a that you had never met with and did not have that relationship as what has been going on during COVID, where their very first interaction may have been with someone online or on a phone call?
I have to say that there are different types of exams and different types of reasons why people would want to use telemedicine first. And I'll notice that Teladoc, their new slogan is virtual first, which can be all right for a few things, but I can tell you stories about patients that would have presented on the phone with a simple question or a simple ask. And when they came into the office, it was not simple at all. And it took visualization to do that. So it might be that, I like telemedicine. I think it's a great tool for the right reasons, and the practitioner should be in charge of that tool. So seeing them with in person is the best. Like this in a box is second best. All audio really should just be if those things break down and they can't be, the person has no access to them. It's just, it's not, it's inferior to all of that, and it puts patients' health at jeopardy. As a 30-year clinician, that's my answer to that. But if nothing else is available and everything else is broken down and that's the only access, then that's better than nothing. There are plenty of times at the end of the day when I would hear patients would leave a note for me, through my secretary and say, call me about whatever, or I would call them with results of tests and we would talk on the phone. But I would only give them bad news or complicated news if I knew them so well, I knew that that was okay. Any other time, I would say, have them come back into the office. I think now my answer would probably be, let's do telemedicine. So at least I can look at them. I can see their eyes. I can hear their voice. I can see who else is with them. But just having it be audio, telephone, that's how I grew up as a physician. For 30 years, that's what I had. And I was aware of the barriers in using that. And you probably, you might know people who say, I can't believe my doctor called me and gave me bad news over the telephone. It's just inferior.
Thank you so much.
Representative Matheson, did you want to ask a question? Okay, so I have a question. You talked about at the beginning of your testimony and the end of your testimony, Representative Hymanson, access, quality, and lower costs as the things that telemedicine had the potential to offer us, but that you had concerns. And my concern is that if we were to pass your bill with the reimbursement parity provision in it, that we cut off all possibility of lower costs. So can you speak to that piece? Because figuring out what to do about reimbursement parity is sort of one of the two central points of this afternoon's workshop or public hearing.
Yeah, thank you for that. And that's a piece that went in the December bill. And as I've been following this, it's very hard because there is a gain to, and I've read through, I've been interested in this. So I've been reading through what's going on in Washington, with CMS and reimbursement and codes and new codes, and everyone's trying to work this out. So this is a complex conversation, which is why I say it might be better to let the dust settle and carry over the bill. I just give you that suggestion because this is a work in progress and with many moving parts to it, and there aren't easy answers to it. But there is benefit to having somebody come into the office. And I think there's a higher cost, people should be able to to charge more to have somebody come into the office because you're seeing, you have all of the ability. It's just a bigger experience to be in an office. And so I think that there should be some kind of differential. However, if you're a provider and you are seeing only people on Tuesday afternoon, by telemedicine, then that's a big chunk of time that you could be reimbursed better for if they came into the office. So you're doing telemedicine at a lower rate when at time you could be charging more if they came into the office. So I don't have a good answer for it. And I'm not sure I agree with my own bill about the parity part. But I know a lot of people are working on this. So that's what I have to say.
Okay, that is helpful ambiguity rather than clarity, but it's always good to know when the sponsor has some reservations or ambiguity about her own bill. Representative Arford.
Yeah, again, thank you so much for being with us, Representative Hymanson. Real quickly, one of the things I've been thinking about is in an in-person visit, you generally don't just see the provider. You see the person who rooms you. You see the person who greets you when you show up and takes your name. You might even have to check in at that. And there's a number of staff members involved that are having to be paid. If you're engaged in just a telemedicine visit, at least the two I've experienced, it's just you and the provider. There may have been someone who set it up originally that was a different person. So to me, there's a significant savings there in the number of staff people involved. So therefore, I mean, I don't know if this is specifically related to your bill, but the way that we structure telemedicine have you thought about how it would be structured? I mean, would doctors be working from their homes? Would they be in offices? Any provider, not just a physician, and how would that relate to what we're trying to accomplish today with passing really good legislation?
It's complicated. I don't have good answers to that. It is a more complex exam when people come into the office. Your blood pressure is taken, your pulse, your temperature. People look at you. They see how you dress. They see how you walk. They have interactions with you. And sometimes my secretary would come up and say, seems a little confused today. And it would give me a hint, and that I could miss that on a telephone call for sure, and even telemedicine call. So there's more complexity about being in person that has a bigger cost to it. I'm just reiterating everything you said. So I'm stuck with this too. I think I would look to guidance from other conversations that have happened at the federal level, because I know those are happening, and at the board levels. But on the other hand, it's time for the physician to be there with the patient. So.
Representative Matheson, I'm going to cut you off, Representative Hymanson. Representative Matheson, go ahead.
Thank you, Madam Leader. Hello, Representative Hymanson, my Southern Belle. So I guess my only comment is that we're talking just about the paradigm of traditional medicine here, where typically a practitioner is doing a diagnostic evaluation. And so a lot of times a physical evaluation is necessary. But there are many practitioners, including myself as a dietitian and owning a naturopathic clinic, where we do significant education that is actually benefited through this telehealth option. And I guess my question to you is, how do you discern that there are different paradigms here and that telemedicine might actually be of equal value in a situation like that?
Yeah, and I thank you for the question. And I am speaking as a physician practitioner in all of those ways. But if I send someone to a dietitian or nutritionist or speech pathologist, physical therapist even, and I knew the patient and I knew their capabilities and that they could communicate in this way, in this manner, then virtual first would be terrific, because then I could send that person to the practitioner that I wanted. So I think that's great. But I think it takes a triage person. I'm talking about the medical field, with a referral now. So all of these things are a little bit different. But if I were going to refer somebody to a speech pathologist, in my mind, I would have a checklist of, can this person interact with telemedicine? Can it hold their attention? Are they able to follow directions? Do they have the mental capacities to do that? Do they have a computer? Do they have stable internet? All of these things I would have to sift through as the referring physician. But again, I'm talking about my own paradigm.
Okay. Thank you, Representative Hymanson. Are there any additional questions for Representative Hymanson? Seeing none, we're going to move on to LD 849, which is sponsored by Representative Matheson. Representative Matheson, you can go ahead, and thank you, Representative Hymanson, for being with us.
Thank you, Madam Chair. Good morning, Senator Sanborn and Chair Tepler, and my esteemed fellow members of the Health Coverage, Insurance, and Financial Services Committee. I'm Representative Christy Matheson. I represent District 1 in the beautiful town of Kittery. I'm here today to introduce LD 849, an act to make permanent the telehealth reimbursement options passed by emergency measures. This is a passionate topic for me as a healthcare practitioner who has experienced significant improvement in patient care during this time in the pandemic. And I think that it's something that has expanded access to care through telehealth access. This is the first bill I considered as a freshman legislator. Healthcare access and affordability are two of the primary issues that I feel are really important to address. Access to preventative healthcare can be challenging. And I emphasize preventative healthcare because that is the healthcare that I'm in an industry in. This pandemic really emphasized how difficult it was to access preventative healthcare in any type of healthcare situations. Telehealth offered us an opportunity to have a good continuity of care, to avoid negative consequences from delayed preventative and chronic or routine care. Remote access to healthcare services helped us increase participation for those who were medically or socially vulnerable, those who didn't have ready access to providers, and ultimately preserved a nice patient-provider relationship when an in-person visit was not practical or feasible. I feel strongly that consistent preventative care is the key to lowering overall medical care costs. I know that the argument here is that utilization may increase when you have more access to preventative care, but I do believe that on the other end, it decreases major medical issues and overall decreases medical costs and healthcare costs. And I feel very strongly that that paradigm and that discussion needs to start. This bill, basically the primary components of 849 include telehealth to include the telephonic audio only service. It requests that the carrier reimburses the telehealth services at the same reimbursable rate as in-person consultation of comparable services. It covers carrier, it requests that the carrier does not offer a healthcare plan that the deductible that's applied to a telehealth appointment would be accumulated separately to the deductible for any other services in the health plan, and also asks that the co-payments and co-insurances provided through a telehealth service doesn't exceed those that are applied to an in-person consultation. And ultimately, it asks that the carrier may not exclude a healthcare service from coverage solely because the service was provided through a telehealth encounter. I know that this is a controversial bill in some respects, and I look forward to more conversations about this. And I know there are other bills that probably we can combine many of the ideas and come up with a really good bill, and I'm very open to that. I don't have to be the sponsor of this bill. I just really feel strongly that we need to have this conversation. So I appreciate your time and hope that the committee can support LD 849. But if you have any questions, I'm happy to answer some.
Representative Evans.
Thank you, Madam Chair. Thanks, Representative Matheson, for bringing this forward. You made a reference to comparable services, and I kind of suspect that that's where the problem is going to be. How would you define that? Maybe something you want to think about, but that would be the thing that I would be concerned about, is how do we define comparable services? What parameters? And that, if we can do that, it may start the momentum one way or the other. So just, that's my thought.
I think that's a great question. I can only answer it through my lens as an integrated practitioner, that I think that the practitioner has to deem whether or not a telehealth service is actually applicable to appropriate care. And if it isn't, then it has to be an in-person visit. So I'm a big fan of having brick and mortar as the primary source, but I think it's really important for the practitioner to have control over whether or not a telehealth call will offer comparable care. And my experiences as a dietitian is that it's actually offered more access and definitely comparable care for education. It's not going to offer comparable care when you want to do a physical diagnostic, and that's when the patient has to come into your facility.
Okay, thanks.
Representative Matheson, I have a question for you about the audio only piece, which is that we've heard other folks, such as Representative Hymenson's bill, suggest like an audio only is allowed if there are barriers to other modalities. And I think your bill would just sort of say audio only is the same. Can you give some feedback on why we shouldn't put that slightly higher barrier in place to say, you got to try to do something with visual technology unless there's barriers to it that are assessed?
Absolutely. Thank you for your question, Senator Sanborn. And I think that the main reason that I was originally wanting to take that part out was due to my own experiences with my elderly patients, where we have spent 15, maybe 20 minutes trying to get a video call set up. And so we go back and forth because the law says that we have to start with a video call. So we end up spending almost half or maybe more than that time trying to get a video call to go through. So the intent of taking that out was to give the practitioner and the patient an option to be able to make a choice on what would work technologically once it was deemed a telehealth call would be beneficial for that visit. Does that make sense? So I don't mind having that criteria in in my bill at all. I just, what I was hoping to get around was that problem that happens on the ground where you're dealing with an elderly patient that just can't do a video call, and we're calling back and forth with the phone, and then we're trying the video again, and that ends up taking up almost the whole time of the visit.
Got it. So something like that, the visual was infeasible, impractical, or otherwise not medically advisable, based on the existing relationship with the enrollee, would be adequate to deal with your situation, rather than just sort of having no parameters at all.
Yes.
Okay, great. Representative Tepler.
Thank you, Madam Chair. And I can completely understand how in a visit with someone who's providing nutrition and dietetic services, a telephonic communication could be perfectly adequate in discussing, what you've been eating and what you could be eating. And sort of what percentages and how much, and all that can be communicated well verbally. I guess one of the things I'm thinking about, and I want to sort of get your take on it, Rep. Matheson, is the idea that these kinds of decisions are to some extent field specific in health. So as I think about it, I think for psychologists, there's so much communicated that's not verbal, that's about facial expression or whatever. So I'm trying to think, and maybe you have some ideas about how to make it possible to talk about rates, broadness of the communication, and all of those things in a way that allows for differences between fields within the health field.
It's a great long question, Representative Tepler. And I think that also one thing to add on to that question is that sometimes actually talking about really difficult things in terms of my eating disorders patients, talking verbally without a visual is actually beneficial. So I understand it's actually a better process than it is to be in person, and they tend to open up even more, and that I would assume sometimes that might happen in mental health. And I think that again, it gets back to a good practitioner. They deem whether or not it's necessary for a patient to be in-house seeing you. A good practitioner knows what their scope of practice is and where they need to see a patient, regardless of what type of practitioner you are. So if you don't know that, then that's taking the personal responsibility away from the practitioner and the client and the patient. And I think that that's not really the legislative process. I think the legislative process is allowing good access and reasonable pricing for care. And I do strongly believe that consistent preventive care with a practitioner is utmost in lowering those prices. So I don't know if that answers your question, but I do think that it might answer a little bit of what you're asking.
I think to some extent it does answer part of my question. So thank you for that. I think there's still some questions about the relationship between rates and that kind of information about a practitioner's choices that remains to be worked out.
Yeah, and I also think that what it does is it automatically, which I respectfully disagree with Representative Hymason, it automatically makes, we automatically say that telehealth is not equal or not as valuable. And I disagree with that. I fundamentally disagree with that. If you have a good practitioner that is recognizing what this patient needs. And I think that that's where I differ in that base. I think that there's as long as your patient is being treated medically, safely, and equally, your practitioner can deem what is necessary with that. So I agree with parts of what Representative Hyman say, but I don't think that telemedicine is necessarily less valuable. For me personally, I have a brick and mortar clinic. I still have to pay for every single thing that I do in my brick and mortar clinic when my practitioners are doing telehealth. So that's, I think, the best type of situation is you have both. You don't just have one or the other necessarily, because it doesn't offer access for everybody and the needs for everybody. Hopefully that answers your question.
I think that to some extent it does again. And I think that certainly as we look at this issue, we have to think about some costs. So,
right, but we also have to think about in a paradigm of healthcare, that overall health costs go down if my patient sees me consistently or talks to me consistently and I keep their blood sugar levels down, right? And they don't go into the hospital for emergency medicine situations. So preventative, continuous preventative care can certainly help with costs in healthcare. And I think that gets lost, even though
that's not what I was referring to. I was referring to the sunk costs of having a brick and mortar office. And that
I see.
if you're making telephonic calls from that office, you have sunk costs in the brick and mortar. So that's what I was saying.
Thank you. Sorry if I misunderstood.
Okay.
Representative Arford, go ahead.
Yeah, thank you, Senator, and thank you so much for your bill, Representative Matheson. And so your incredibly thoughtful and passionate commitment to something that you clearly believe is in the best interest of the people of our state. I really appreciate that. It's really interesting. I have noticed that all of us, including myself, view this primarily, at least at first, through our own experience with telemedicine or with telehealth or with the idea of it. And so my perspective comes through that of the patient. And that's why I've continually asked people, what do you have to share with us? What data do you have to share with us that is directly reported by the patients on the services that they have received? And so I'm going to ask you that. Do you have anything to share with us? Surveys that you've collected from your patients or anything that directly reports their experience of receiving telehealth services or telemedicine services from you?
So we haven't done a specific survey on whether or not they like those services more or better, but we have seen a significant increase in care between our practitioners and our patients. And when offered either or, I would say we had about a 25% increase in the option for a telehealth call instead of an in-person call. And we had about a 20% increase in continuity of care. So that kind of told me that the patient wanted that option, chose that option, as long as it was medically deemed correct by all of our practitioners. But we didn't necessarily say to them, have you liked this better or worse? But we have certainly asked them whether or not they wanted to use the service.
Right. Well, if you do in the future generate data, of that nature, I would certainly love it for you to share it with me, because I'm very interested in directly reported information from patients. And thank you so much again for bringing this bill to us.
Thanks for your question.
All right. So next we will hear from, I think, still Representative Morris. We're like 4 minutes away from when I think Senator Stewart's going to join us. Do you want to hold off? He could give his testimony while we're still in the proponents section if you want, Representative Morris.
I don't know that he will be coming over or not. I haven't.
Oh, okay.
Yeah, I knew one time, but I don't know if he plans to join us at all. So.
Okay, great. Go ahead, Ben.
But I'll be happy to. Yes. Thank you, Senator Sanborn, Representative Tepler, and colleagues on the legislature's Health Coverage, Insurance, and Financial Services Committee. I'm reading testimony today of Senator Trey Stewart from Aroostook on LD 649, an act to expand and promote telehealth services. As we have heard many times, the medical and technology sectors have been making improvements at a rapid pace. We saw this to be particularly true over the last year as people adapted to working from home and communicating with loved ones via Zoom, but who were simultaneously unable to see their physician for routine and minor medical issues. Living in a rural part of the state, the benefits that come with telehealth are attractive, as it often results in less travel time, cost savings, and greater flexibility in scheduling a patient-physician visit. For example, if patients in Fort Kent no longer have to drive to Portland to see their doctor every month, the cost savings in gas, lodging expense, and time are substantial. The bill before you would make telehealth more readily available to Mainers while strengthening the licensing laws around physicians not licensed in the state of Maine providing telehealth services to Maine patients. With the patient's consent, a physician may perform telemedicine using the patient's choice of telecommunications technology. This idea would have a significant benefit to rural Maine and even those living in rural parts of our state who would now be able to visit a specialist from out of state. To ensure that physicians are meeting Maine's standards of practice, providers from outside of Maine must follow our medical licensing laws and shall be registered by the Maine Board of Licensure to provide telehealth services. In addition to being registered by the board, they will be required to pay a fee of $300. The securities are in place with this proposal to ensure that Mainers will be receiving quality health care, but able to do so without incurring the added unnecessary expense of travel. This is not just a nebulous idea, it has real-world implications. For example, a constituent of mine reached out last year whose wife needed the treatment of a specialist for a psychological disorder. Prior to the governor's executive order allowing for as much, she was unable to get approval to even have a phone call with his specialist. Well, this was one of the silver linings of the COVID pandemic. It should not be this challenging for Mainers to access the only forms of health care that they need, particularly when it's not available in the state. Forcing them to travel from Aroostook County to New York City because we haven't updated our statutes in this area is simply unacceptable. Please join me in supporting this policy so that regardless of your zip code, you can access quality health care without incurring unnecessary expenses to get there. Thank you for your time and consideration of this important issue.
Thank you, Representative Morris, for presenting testimony on behalf of our colleague. And so with that, I'm going to do my very best to try and integrate these for and against lists. I'm wrestling a little bit with the fact that everyone seems to have signed up twice. Like twice for each bill. So I think we have some technology glitches in the lists. So bear with me as I stumble along through those lists, and we will certainly give folks a chance to raise their hand at the end of the proponents section, the end of the opponents section, and the end of the neither for nor against section in case I miss anyone as I try to integrate these lists. First up, we're going to call on Jasmine Bishop.
I do not see Jasmine Bishop on the call anymore.
Great. I mean, not great. I'm sorry that it's late in the afternoon and we missed Ms. Bishop, so I don't mean it in that way. But moving on, we will call on Pam KL.
Pam also called. She's not on the call anymore.
Okay. Next up on the list is Patsy Katzos. Good afternoon. Go ahead.
Thank you. And good afternoon, Senator Sanborn, Representative Tepler, and distinguished members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Patsy Katzos. I'm a registered dietitian and I'm a resident of Portland. I'm speaking today on behalf of the Maine Academy of Nutrition and Dietetics in support of these bills, LD 323, 333, and LD 849. And it's very exciting to be able to support a bill put forward by one of my colleagues. In my work as a registered licensed dietitian, I am a consultant at Nutrition Works in Portland, providing one-on-one nutrition therapy to patients with gastroenterology problems. Our services lend themselves very well to telehealth, but I agree with Representative Matheson that our business costs are not reduced at all by telehealth. We still have to pay the salary of our office staff, rent for the building, and so on. You know, it may be that there has to be some differential consideration for reimbursement between, you know, practitioners who offer telehealth in addition to their office visits versus those who, you know, perhaps are working for a company that is devoted entirely to telehealth. So we are in support of these bills, but based on our pre-pandemic claims experience for telehealth visits and the billing and claims that we've handled since the pandemic, we recommend a few changes to the bills as relevant. First of all, ensure that the provider is of the patient's choice. As for inpatient visits, and I feel these comparable services could be defined as governed by the insurance contract that the patient has with the payer. Before the pandemic, some payers were meeting only the letter of Maine's telehealth law by offering telehealth nutrition services only from their own employed health coaches or national contractors. We feel that your local doctor wants to refer you to a trusted local expert for specialist care. Ensure that the term healthcare services does include nutrition services specifically and or medical nutrition therapy. Ensure that Maine residents with policies that cover nutrition services get reimbursement of these services at the same rates and copays as face-to-face visits. You know, we're finding that even during this present emergency, that there are several payers who are reimbursing us at lower rates for the same nutrition services when provided via telehealth, whether they're supposed to be doing that or not. That's what's happening on the ground. And many patients, you know, decide not to receive telehealth services if we have to tell them that we aren't sure whether insurance would pay for it or not. That's not happening right now, you know, with the current requirement that telehealth be reimbursed. So that's pretty great for our patients. We feel patients benefit from a predictable environment where they know how much their services will cost and whether their insurance will pay for it before they receive them. All in all, we urge you, the members of this committee, to support LD 323, 333, and 849. And we welcome the opportunity to be here today and welcome your questions. Thank you.
Thank you, Ms. Katsos. Are there questions for Ms. Katsos? All right. Seeing none, we thank you for providing your testimony.
Pleasure.
And next, we'll hear from Mr. Dixon. Welcome back, and please go ahead. You have 3 minutes. You're on mute at the moment. You're still on mute. We can't hear you.
Yes, and I see
go.
that too, because there are things popping down in front of where I am that keep me from clicking what I need to. I'm not even going to present anything from my testimony, the prepared testimony, because I've submitted it and I'm hoping that people will read it. This is you know what, I think you're dealing with questions and with decisions that are very hard to make because you are trying to deal with multiple providers, and each profession has a little bit different need with regard to telehealth. So I'm not sure what you do with that. It's part of why I appreciate what you folks are doing and how hard you have to work. I've been here for pretty much the whole time that you have, and I'm tired. And please let me know when my 30 or 3 minutes are up, because I'd probably keep on talking for 30 minutes. Thank you. So I just, I wonder about compacts as a way of maintaining a better quality of care. And I'm glad that we're going to be, the psychologist, MEPAS, is going to be getting information that will help you with that in terms of what it means, in terms of the licensure law. I think that's very appropriate to be concerned about. Having a variety of specialists and using telehealth to do that makes a lot of sense too. So I hope that you'll be able to come up with a bill that really rings everybody's bell, So thanks again. I'm going to stop talking here. I'm going to stick around and see the rest of the hearing. I'm going to make sure that you get answers to the questions that you ask of our president and our executive director. And hopefully that will help with the process of figuring out what you're going to do with all these bills.
Great.
Thank
Thanks.
you. Thank you for allowing me.
Thank you. Thanks for sticking with us today. We've been doing it for 2 days prior to today as well this week. So we've had a long week already.
I'll bet.
And so thank you for being here. Next, we'll hear from Bruce Garrity.
Good afternoon, Senator. Again.
Good afternoon. Go ahead.
Senator Sanborn, Representative Tepler, and members of the committee. On this last category of bills, I think rather than go into each bill in detail, we do support Representative Perry's bill, which relates to a broader use of telephonic care. I'd like to point to, I think, Representative Hymanson's bill, which puts in stark contrast the kind of decision that I think that the committee needs to make. If you look at LD 333, it says that you can use audio only when there's no other means of interactive real-time visual aid, or there's a lack of electronic media, a lack of broadband access, a lack of other means, or it's infeasible, impractical, or otherwise not medically advisable. Which puts real shackles on its use. But then it goes on to say, as determined by the provider. We respectfully feel that this is an individual's medical care, that the individual should have a say in what kind of care they're going to receive, from whom they receive it, and the modality of care. This is a gatekeeper provision that leaves the matter entirely in the hands of the underlying healthcare provider, and we respectfully disagree with that approach. And I think that's at the heart of where the committee needs to make its decisions. The second point I would make, and again, this isn't just Representative the LD 333, it's several of the others. If you have the same pay scale, so to speak, if I can put it in that kind of pedestrian way, then where are the savings? I agree with Representative Matheson's point and the point of some of the other proponents that it may be different if you're providing both in-person care and virtual care in Maine, as opposed to virtual care somewhere else. That can be sorted out from a rate or a reimbursement process, but we don't agree with the notion of pay parity right across the board, which is what that bill calls for. The only other point I would draw the committee's attention to is the provision in Senator Stewart's bill that references Title 32, Section 330, capital D, which involves registration for physicians when telemedical services are being provided out of state. First, it is a registration process, not a licensing process, which we think the committee might want to think about. Second, if you take away the provision that says it's only when the providing physician says it's necessary, not providing, the underlying physician says it's necessary, then we think that that gives you a registration process that you can consider as you move forward with these bills. But we do think you have a stark question to answer or evaluate as to who makes the decision, the patient or the physician. And we respect.
Thank you, Mr. Garrity.
Thank you.
Thank you, Mr. Garrity. And I just want to flag for the committee, and Mr. Garrity will probably appreciate this as a longtime front row sitter in our committee, that actually this paragraph that's amended in all of these bills is about whether the insurer gets to make the decision, just to add further complication to the question of who gets to decide what technology is appropriate. So that'll be another important piece for us to wrestle with, because these bills we're talking about right now amend 24A as opposed to 22. So they're about what insurers get to do. That wasn't a question, Mr. Garrity, but are there any questions for Mr. Garrity?
I was going to say, did you say, isn't that so at the end?
Isn't that so? All right. Yet more for us to wrestle with as a committee. So thank you, Mr. Garrity. We appreciate your chiming in. It's certainly difficult to say whether someone's in favor or against this grouping of bills, because it does have a lot of different elements to it. Next, we'll hear from Lisa Harvey McPherson.
There. Good afternoon, Senator Sanborn, Representative Kepler, and committee members. My name is Lisa Harvey McPherson, and I'm pleased to be with you this afternoon speaking in support of these bills. Northern Light Health is proud of our clinical and technology expertise as a leader in telehealth, and we are honored for the work that we have done with this committee and the Health and Human Services Committee on telehealth. I had the opportunity to speak with Senator Gratwick in the early stages of COVID, and we spoke about how important it was, all of the foundational work that we did, expanding telehealth coverage. And the bills before you today point out our opportunity to make that coverage even better. And so I'm honored to have worked with the committee on this. To put in context what COVID has meant for telehealth for Northern Light Health, last February, we did about 1,500 telehealth encounters a month. By May of last year, we did 33,000. And today we average about 20,000 telehealth encounters per month. COVID has transformed our technological support for how we deliver care. I know that Representative Alford is very interested in patient feedback. So we ask our patients who receive telehealth services for pre and post-surgical care, rheumatology, cardiology, neurology, gastroenterology, orthopedics, oncology, women's health, pediatrics, and primary care. And our biggest transformation has been in behavioral health. We asked them how satisfied they were with the telehealth service, and 60% report that they are highly satisfied. And when we do a deeper dive into those who report lower satisfaction rates, it's not the clinical service that we provide, it's their broadband challenges, or the challenges they have with the technology equipment in their home. That's what they tell us was the source of that lower score. So I'm going to talk about some components in the bills before you today, and I'll start with telephonic coverage. Telephonic coverage is not our first choice of how we care for our patients. But because of our broadband challenges, and we've talked about this before when we were working on the prior bills a couple of years ago. Because of our broadband challenges, we don't have the speed and the width of the highway to support a high quality visual encounter for many patients. That's when telephonic coverage really became very important in the past year. When COVID first started, we didn't have our Zoom structure set up, and so we were calling our patients. But then as we did more and more telehealth, we understood the broadband challenge in a real-time way. And that's when telephonic became important. And I know that with the carrier discussions we've had, there have been recommendations from the carriers that the provider must document every time why telephonic is the mode of service for that visit. It's reasonable to have some bumpers around that. And what we would ask, if you go down that road, is for the provider to document it once in the patient's chart. They don't have broadband today, they're not going to have it tomorrow. So we think that's a reasonable compromise. Ann Perry's bill has a specific component around verbal consent. And this is in main care policy, but it's in this bill. And it's important to allow patients to continue to verbally consent for telehealth services. When you interject paper that we mail to a patient and they mail back, or email, and you interject that into an electronic medium, you're just creating opportunity for error, quite frankly. So allowing patients to continue to verbally consent is critically important. You've talked a little bit about payment parity. We certainly support payment parity. We have different cost structures that are related to telehealth. And our Zoom customer service center is one of those new cost structures. Admitting patients into a telehealth service is a new cost structure. And the post-encounter work is a new cost structure. And Representative Matheson is right. We haven't closed our offices. We haven't closed Acadia Hospital's outpatient department. So we still have infrastructure carry while we're doing technological services. The bill also, LD 333 has a section on prescriptions. When we negotiated the prior telehealth changes, we had a standard around prescriptions that you can't write the initial prescription on a telehealth encounter. Well, we've written lots of prescriptions in telehealth encounters. And I think Representative Hymanson is right. That really is provider discretion. We need to allow the providers to practice safely using technology and their judgment when it is safe to prescribe via telehealth. And in terms of telehealth covered services, I spoke about that this morning. The variety of professionals, if we shut that spigot off, the consumers are telling us they like it. They like it. And so we want to be able to make sure that we meet their needs. And the discussion of telehealth dietitian services is a really good example of that. So I would welcome any questions that you have. I did a quick overview because you've had a long day, but I'm certainly willing to expand upon anything that's helpful.
Thank you, Ms. Harvey McPherson. Are there questions for Ms. Harvey McPherson? Representative Hartford, go ahead.
Yes, thank you so much for being with us today. I think that you're one of the people who has really shown up for our committee this session, and I appreciate it. I also appreciate you following up. What I'm really looking for, though, is the actual report, because we've had a number of providers report to us that they're, as you have, but would you be able to send us a copy of whether the survey summary was or whatever it is that you were reporting off of?
Yeah, what I'll ask if I can, I think it would be interesting for you all to say, what do we ask them? And kind of what are they responding? I'll see if I can get that for you.
And again, thank you so much for following up on that. I truly appreciate it.
Great, I'll be glad to do that.
Ms. Harvey McPherson, what I was about to say before I realized that Representative Arford's hand was up was that I had been trying to find where that consent provision was located. It's in the licensing statutes, I think, or it's in Title 22 at least. I'm curious whether if we don't pass that section pre-pandemic, was there some provision was it in board rules that you had to get consent for telehealth on paper? I'm trying to figure out why that's a change that needs to be put in statute.
It's really in behavioral health. That's really where that came from. And if you think about behavioral health, and Acadia is a good example, we almost overnight transformed our behavioral health outpatient service to all technology based. And the department had consent that was a requirement around a paper-based system. So we were able to negotiate around that during the pandemic, and we want to continue that. And I realize it's chapter 22. If you don't move this, because it is main care policy, a letter from the committee and asking the Health and Human Services Committee to take a look at this would be important, because this little line is a huge issue in the behavioral health world.
Got it. And so that little line is in main care reimbursement provision.
It's main care.
Got it. Not licensing.
Yep.
Okay. That's why I was confused, because it seemed like an odd thing that we would need to deal with. And that's why, because we're in a section of statute that I don't usually play in. So that's fine. No, we're able to make those types of changes if we need to in a combined situation like this, but that does explain to me why I was unfamiliar with that provision. So that's really helpful. Are there any other questions for Ms. Harvey McPherson? All right, seeing none, thanks for your testimony. And next, Representative Quint, I didn't see your hand. Sorry, go ahead.
Sorry, I was trying to find the button. I'm just wondering, Ms. Harvey McPherson, if the data you had, like 60% of the people were pleased with the telemedicine, was it specifically more like in behavioral health? Do you have a breakdown of the different, because I know you listed many different. Right.
I will find that out when I ask the questions. I'll find that out.
Thank you. I think that would be very beneficial.
Yeah.
All right. Next, we will hear from Susan Woods. Good afternoon, Ms. Woods. Go ahead.
Hi, it's Dr. Woods. Nice to see everyone.
Dr. Woods.
I'm Sue Woods. I live in Harpswell, Maine. I'm a general internist and a researcher. I've been working in virtual care and digital health for over 15 years. My career in virtual care began in 1999 when I founded the Maine Tobacco Helpline. And I also served as the telehealth representative on the Connect Me Authority for 4 years. I'm here in support of 323, 333, 649, and 849. My comments focus on research and evidence, access, and positioning Maine for the future. The evidence for telephonic intervention has been available for decades. The Maine Tobacco Helpline has delivered phone-based behavioral counseling for 21 years. They had published research that showed effectiveness and reach. Their quit rates rivaled those seen in rigorous trials, and people from all over Maine receive services. Much care can be delivered by phone, discussing treatment, monitoring conditions, giving psychological support, and addressing end-of-life care, and these are established in research. Ask any clinician or adult in Maine today, and they will confirm talking by phone is beneficial and can augment in-person care or substitute for an in-person visit. Second, virtual care is healthcare. People want care at a distance, at home, school, and work. Patient portals, telehealth, remote monitoring, and mobile apps improve health and lower costs. Telehealth, audio and video profoundly improve access to care and should not be placed in a separate technology bucket. Removing requirements such as medical necessity, allowing verbal consent, and using the patient's own technology will make sure that we will achieve digital health equity. Parity must occur with virtual care and in-person care. As a physician, I may not be able to do a full physical exam with a video, but I gain tremendous information about a person's life, or I can bring in a family member that lives somewhere else. Medical visit coding and encounter requirements already have the necessary guidelines and guardrails to determine the level of effort that practitioners provide in a visit. Parity must mean what is done during encounter, not what type of encounter it is. Lastly, our policies must support virtual care in the future. We must not micromanage clinical encounters by the channel which is provided. Today it's in person, video, and phone. Tomorrow it will be augmented reality. And as you work through all of these bills, please ask the question, what happens today with in-person care? Are you creating a higher standard or level of complexity with virtual care? I respectfully request that you not introduce more complexity in a system in our lives that is already complicated. Thank you very much.
Thank you very much, Dr. Woods. Are there any questions for Dr. Woods? All right, seeing none, we thank you for being with us today. And next we'll hear from Alexander Chu.
I do not believe Alexander Chu is on the call anymore.
Okay. Next we'll hear from Kate Endy.
Thank you, Senator Sanborn, Representative Tepler, and members of the committee. My name is Kate Endy, and I'm the Policy Director at Consumers for Affordable Healthcare. I believe I'm registered to testify in support of LD 333, but speaking more generally about the group of bills expanding access to telehealth services in support. You've had a long day and have heard time and again the many benefits of increased access to telehealth. Maine's one of the most rural states, and we hear from people through our helpline all the time who have to travel long distances in order to see providers. And the pandemic has shown us just how effective telehealth can be. So I won't get into the details there because there's others more qualified than me to talk about that. What I did just want to mention is while telehealth is a critical tool to help reducing barriers and improving access, we also recognize that there are a lot of complicated questions the committee will have to grapple with, and that the decision to use telehealth rather than an in-person care when deemed appropriate by the provider should still remain the choice of the patient. And I think Representative Quint earlier raised a valid concern around making sure that telehealth doesn't become the only or the primary mode of care, especially in rural areas. And so to this end, in addition to the numerous other complicated issues the committee has already discussed regarding reimbursement rates and cost sharing under health coverage, I would suggest the committee may also want to consider potential impacts or issues relating to provider networks. Carriers offering managed care plans have to provide reasonable access to healthcare services for their members. And similarly, in Maine, state law requires carriers that offer prescription drug benefits to maintain a reasonably adequate network of pharmacies. And while not exactly the same, mail order pharmacies like telehealth can be useful in reducing barriers in some instances, lack of transportation, for example, but in other situations may not be an appropriate or best way to deliver that service. And so for that reason, Maine actually prohibits mail order pharmacies from being considered when determining the adequacy of a carrier's retail pharmacy network. And along the same lines, I think it would be important for carriers to not be able to include telehealth providers for the purposes of determining the adequacy of their provider network and accessibility of services under a health plan in order to ensure that Maine people continue to have access to telehealth when appropriate and when they choose to, but are still able to go to their local health center or receive in-person care from the independent providers in their community. And with that, I will thank you for grappling with such an important issue and improving access, and happy to answer any questions.
Great. And you finished right at 3 minutes. Thank you, Ms. Endy. And you've brought up an important issue that we hadn't, that I know I hadn't thought of yet. So thank you for putting that in the forefront. Are there any other questions for Ms. Endy? All right. Next, we'll turn to Caitlin Morse. Ms. Morse, we've got a blank screen. Are you there? Now you're there. Great. Go ahead.
Here. Good afternoon, Senator Sanborn, Representative Tepler, and members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. As I embarrassingly said before, my name is Caitlin Morse. I am a resident of Westbrook and the Policy Associate of the Alliance for Addiction and Mental Health Services. I am here to read testimony on behalf of Mallory Shaughnessy, the Executive Director of the Alliance for Addiction and Mental Health Services. Please accept this testimony on behalf of the Alliance in support of LD 323, 333, 849, and maintaining expanded telehealth services. LD 323, 333, and 849, as well as a few of the other bills before you today, make permanent several aspects of the Governor's Executive Order number 35, dated April 6, 2020, which allowed certain licensed or registered professionals under title of the Maine Revised Statutes to provide necessary health care or other services to the extent practicable through the use of all modes of telehealth, including visual and audio only or other electronic media. These bills clarify that these services must be covered by insurance as they would be if provided in person. They also allow patients receiving Maine Care Health Services to provide verbal, electronic, or written consent to telehealth and telemonitoring services. The Alliance supports rolling these bills up into one omnibus bill that permanently leaves the enhanced access to care that was one of the few silver linings of the pandemic. Through the expanded telehealth options, many Mainers were able to access services in geographic areas of Maine that aren't usually covered due to their rural nature. Many Mainers were able to receive services on a regular basis who often miss appointments due to unstable transportation. Many Mainers who struggle to leave their homes were able to meet face-to-face with therapists. This expansion added a very useful tool to the healthcare toolbox for our practitioners, and we don't want to see that go away. Thank you.
Thank you very much, Ms. Morse. Are there questions for Ms. Morse? All right, seeing none, we thank you and Ms. Shaughnessy for your testimony. And next we'll hear from Megan Pudler. Good afternoon, go ahead.
Hi, good afternoon, members of the committee. My name is Megan Pudler. I'm a State Affairs Manager at the American Occupational Therapy Association. Thank you so much for the opportunity today to testify in support of LD 333, an act regarding telehealth. I've submitted written testimony, so I'm just going to touch on it briefly here. But the coronavirus pandemic has required healthcare policymakers, payers, and providers alike to reconsider how care is delivered We greatly appreciate the expansions and flexibilities that Maine has adopted for occupational therapy services to this point. The ability to supplement or replace in-clinic occupational therapy sessions with those provided through telehealth has been especially beneficial for patients who have mobility issues and find it difficult to leave their homes without assistance, who lack transportation and or need to travel long distances. Benefits of telehealth include increased access to OT services for children and adults who live in remote areas, the prevention of unnecessary delays in receiving services, and coordinated care among team members in different locations. The expansion of telehealth payment and practice policies on the state and federal level during the public health emergency has demonstrated not only the many needs that can be met effectively using technology, but that patients also have improved access to skilled care by leveraging telehealth resources. Health professionals, including OT practitioners, who had to rapidly deploy telehealth services, were still able to support their patients and positively impact outcomes. With that, thank you for your time, and please support the passage of this very important legislation, which would allow for more access to occupational therapy services for individuals in Maine.
Thank you very much, Ms. Pudler. Are there any questions? All right, seeing none. Next, we'll hear from Mary Tedesco-Schneck. Good afternoon again. Go ahead.
Yeah, good afternoon. Thank you. I've been scribbling along here so I could just add to the conversation and not repeat things. So Senator Sanborn, Representative Tepler, and distinguished members of the committee, my name is Mary Tedesco-Schneck. I'm a practicing pediatric nurse practitioner at Penobscot Pediatrics, and I'm an assistant professor at the University of Maine in the School of Nursing. I also serve as a member of the board of the Maine chapter of the American Academy of Pediatrics, and I'm here today representing both the University of Maine and the Maine chapter of the American Academy of Pediatrics. I'm not going to read my whole testimony because you have it. I just wanted to address some of the things that I heard in terms of questions and thoughts that everyone had. And so I've been in practice for about 37 years. In primary care and walk-in care. And telehealth is just one more tool that we have to deliver healthcare, but it has been demonstrated to improve quality. And so the question that's been raised is, how do we decide if telehealth is the best way to deliver these services? Well, it's the same way we decide before we had telehealth. That decision is made between the provider and the patient and the nature of the visit. So that piece won't go away. And then lastly, I'd like to just say that this also brings opportunities to have partnerships between education and healthcare that improves quality of care. So I'm just going to talk, I'm here in support of LD 333, and I am just going to talk a little bit, just give an example of that. So I'm going to illustrate this point, which I think talks about preventative care with a focus on pediatric asthma. So you know that Maine has one of the highest rates of asthma in the nation, and there's a huge economic burden with that, which is ER visits, hospitalizations, as well as significant personal and societal costs. So for a child who may come into the emergency room for an exacerbation, you know, not being able to breathe, being admitted to the hospital can be scary things. And for parents, multiple visits equate to lost work time and income for parents for missing time from work. So what telehealth provides for us with this is we do actually asthma education in the office traditionally, but it's multiple visits in order to help that child to maintain a level of a good level of care. So telehealth provides an opportunity for us to work with children, adolescents, and families on things like asthma education, monitoring symptoms, and tailoring our education. And we do have equipment that we can use, such as pulmonary functions tests in the home to help monitor those things. And then lastly, just to bridge that gap between healthcare and education, through the University of Maine, we got a grant to purchase telehealth equipment to teach nurses how to train them how to work with telehealth. So thank you for your attention, and I just wanted to highlight those things.
Great. Thank you for being here, Ms. Tedesco-Schneck. Are there questions? All right, not seeing any. We thank you for adding to our conversation today. Next on my list would be Charlie Dingman, but I don't see him in the meeting.
No, he had to leave.
Okay, and he did submit written testimony. Next would be Nick Murray, but I think we got a note from him that he wouldn't testify either. And so next would be Mark Punt. Good afternoon, Mr. Punt. You can, there you go, go ahead.
There you go. Are you able to hear me?
Yes.
Thank you. Good afternoon, Senator Sanborn, Representative Tepler, and the respective members of the committee. I'm Dr. Mark Punt, and I reside actually in Portsmouth, New Hampshire, and I'm the President and Chief Medical Officer of Convenient MD. I thank you for addressing the number of telehealth bills that you've addressed today, and I'm speaking in support of LD 849, sponsored by Representative Matheson, addressing the issue of payment parity. To give you the perspective of where our thoughts are coming from, Convenient MD is a leading walk-in virtual urgent care provider dedicated to delivering the best medical care and patient experience throughout Maine, New Hampshire, and Massachusetts. So we have both telehealth services and in-clinic bricks and mortar services. At Convenient MD, patients with non-life-threatening illnesses and injuries can be seen virtually or just walk into one of our 26 urgent care locations, 6 of which are located in the state of Maine. 3 more will be built within the next 18 months in the state of Maine. So I too submitted written testimony, and I'll just give some points that have been brought up in the discussion that I hope will be helpful. First of all, with increased access, we have provided telehealth since the beginning of the pandemic, and we have noted that in Maine, 40% of our telehealth visits are beyond the markets that our current clinics serve. So we've expanded that market significantly, enhancing access to rural communities. Also wanted to note the point of cost. You know, when we think of, at first, the thought of cost relates to how does the cost of a telehealth visit equal the cost of an in-person visit? But I want to echo the points of Representative Matheson that total healthcare cost is what matters. What we have found is by being able to intervene in it for urgent care type injuries or illnesses, we can prevent downstream ED referrals and downstream referrals to specialists that are higher cost, thereby reducing the overall cost of care. The other thing to note on that was there's a question of what parameters can be used to judge or to determine what services are provided and what should be paid in parity. And one of the other people who testified noted that the coding guidelines by CMS, which are based on medical decision-making, can be used and provide the parameters to determine what level of service is provided and then what payment would make sense. Representative Arford also asked some questions on patient satisfaction. And we measure patient satisfaction in clinic and via telehealth. And we've had over 50,000 telehealth visits over the last 8 months. Our NPS scores, Net Promoter Scores, were 85 for telehealth and 84 for in-clinic. And so basically they're very similar as well. When looking at reimbursement for telehealth, I think it's important to understand the infrastructure costs. There's of course the cost of the personnel, and there are personnel who do intake, and there's also additional personnel time often for the provider because there is not the nurse or the clinical team member doing triage and intake. That is done often by the provider extending their time, and they are a higher cost team member. Also, medical malpractice costs are the same. There's also the the need to invest in
Dr.
technology.
Pun, can you wrap it up for me?
Yep. So increased technology needs, platforms, bandwidth, that type of thing. So I thank you for your attention to all of these matters, including the LD 849, and have a good day. I'll answer any questions that you may have.
All right. Thank you, Dr. Punt. Representative Quint, go ahead.
Thank you. And thank you, Mr. Punt. I'm just wondering if you can list the 6 locations that you already have and the 3 new ones that are due to be built.
Yep. So we have a site in Saco, Portland, Westbrook, Brunswick, Bangor, and Ellsworth. The next one to open will be in Augusta, then Sanford, then Auburn.
Just a follow-up question. Have you had any interest or has anyone asked about locations in either Washington County or Aroostook County?
We have not been asked to look at those, but we will, as we look at servicing the entire state, we'll look at any communities that you would like us to look at and see and determine the best way to service them.
Thank you.
Representative Arford.
Yeah, just quickly, same question I've asked of everybody else. Would you be able to send us a digital, or I'm assuming digital copy of the survey that you just reported out to us on?
So the we can give you the report of the data. It's actually a text that is sent to every person that we touch, whether it's in clinic or telehealth, and they by responding to an answer on that text determines the Net Promoter Score, and then we tally those over each day and then over a month, and that's how we do it. So it's a single question asked about the quality of the service and would they recommend that service to a friend or family member.
And it is in a report form?
The scores are in report form, yes.
Okay, thank you very much.
Sure.
Senator Brenner.
Thank you, Madam Chair. Thank you, Mr. Punt, for being here. I'm wondering in your organization, if I'm assuming you're keeping data about the type of visit that the client has. Absolutely. And their demographic information. So you have some data. Do you collect data on outcomes after the visit at all?
That is more difficult because often the patient, we are not a primary care provider, we're a episodic care provider. So we will refer back for follow-up to the primary care or to a specialist when appropriate. Could be related if it's in clinic to orthopedics, if it's telehealth, it could be ortho or pulmonary or specialist. Most of our information that shows outcomes is related to how many people need to be referred out either to one of the things we do offer is what we call last mile care. About 80% of the population of Maine, once we have our 9 clinics up, will be in a 30-minute drive time to one of our clinics. So if something cannot be handled by telehealth, they can be referred into us. And of course, there's conditions that need referral to the ED because of the severity. And so our outcomes data shows more need for referrals. That's the main outcomes data that urgent care networks follow.
And do you report data at all into the Maine Health Data Organization for the number of telehealth visits you're doing?
We do not.
Okay.
We'd be willing to.
Like getting to this larger question of overall cost for the healthcare system versus specific cost for an insurance carrier to reimburse for parity for a visit. I guess my mind is going to that next step for that next bill that we need, which is about how can we collect data on outcomes for telehealth visits through MHDO and use it to show cost effectiveness for the treatment modality.
We'd be happy to participate in any way we can to help with that.
Thank you so much.
Thanks, Senator Brenner. Are there any other questions? All right. So seeing none, you're welcome. Thank you for joining us. And I just want to double check my lists here, but I think we're getting to the end of the folks who had signed up to speak in favor of these 4 bills. So if you had hoped to testify in favor of one of these 4 bills, please raise your electronic hand at this time. Someone raised their hand. Ah, okay, we'll bring over Ann Robinson. Good afternoon, Ms. Robinson. Go ahead.
Thank you, Senator Sanborn, Representative Tepler, members of the committee. I am Ann Robinson. I'm a lawyer with Pierce Atwood, a resident of Portland, and I'm here on behalf of Spectrum Healthcare Partners. You heard earlier today from Dr. Herbert Cushing, who is Spectrum's chief medical officer, and he regrets that he wasn't able to remain for the entirety of the hearing. He had intended to testify on these bills as well. And so I will just say that we are in favor of these bills, with the exception of 649, but the other bills, insofar as they recognize that telehealth is a valuable and appropriate option for patients in certain circumstances. And when rendered in those circumstances, we think it follows that payment parity is also appropriate and justified. I know some other people who testified earlier spoke to the fact that that there isn't a lesser amount of resources and time that are utilized to provide telehealth services. In fact, it can often be, quite the opposite. At the same time, it can be a cost savings and certainly a convenience to patients. So there's that, value on the other side as well. So we are, as I said, just in favor of all of them insofar as they seek to, achieve both payment parity as well as the recognition of the fact that there are times when audio only is the only option, given Maine's lack of bandwidth and all. If you prefer, Senator Sanborn, Representative Tepler, I can just simply say while I'm here that we oppose 649 for the same reasons that Dr. Cushing articulated with respect to the bills that were heard earlier this morning.
Thank you, Ms. Robinson. And yeah, just to be clear with folks, 649 sort of straddled the line because it talked about both the audio only piece and the licensing piece. So I think that was part of, it's a little bit of an outlier in terms of where to put it in today's hearing. So I appreciate the difficulty there. Are there any questions for Ms. Robinson? All right, seeing none, I am going to ask if anybody wants to testify in opposition to this chunk of bills. Because of 649 going back over some of the licensing stuff, we can certainly hear again from folks on that if we want to, but we did already sort of talk about, I think, some of those issues. So please raise your hand if you'd like to testify in opposition. Okay, we'll bring over Mr. Terranova from the Board of Medicine. Good afternoon, Mr. Terranova.
Good afternoon again. Thank you, Senator Sanborn, Representative Tepler, and members of the committee. I will try to make this short. I am speaking in opposition to LD 649. When Representative Matheson was introducing her bill, she talked about how it seemed like telemedicine was undervalued or devalued. And I think that there's a perception here, and it has shown in some of these bills today, that there's less harm that can come from telemedicine and that it doesn't need to be as regulated, or that it's easier to regulate telemedicine. And that's simply not true. Telemedicine, again, is a practice of medicine. It's not a specialty. All specialties can practice telemedicine, or most. So I just want to point to this specific bill, it makes changes to section 30 or section 32, section 3300D. That's a bill. It was only enacted in 2015, and there were less regulations for those licensees who wanted this kind of registration or license. And to the Board of Medicine, a registration and a license are really the same thing. The reason there were less is because of paragraph C, which has been struck from this version of the bill. And what paragraph C did was say that there had to be a fully licensed main physician or physician assistant who maintained control of the treatment of the patient. So someone from outside could consult and they could communicate with the main licensed physician, but that fully licensed, fully vetted main licensed physician or physician assistant had control over the patient's treatment. That's removed in this bill to simply allow people who go through a sort of a fast track licensure and not verified as much to practice telemedicine in the state. It also allows them to open an office in the state, which was prohibited in the current version of the law. So it removes a guardrail and it for patients because there's no more in-state physician responsibility, and it discriminates against physicians and physician assistants living and working in Maine. And I know we've talked a lot about licensure in other states and different levels of verification. And I just want to mention again that we work with the Interstate Medical Licensure Compact. We issue licenses within 72 hours through that compact. As the immediate past chair of that compact, I can tell you that it works. And we see a lot of good coming through that. But again, telemedicine is the practice of medicine, and this bill reduces the regulation and again, stops us from being able to completely protect patients in Maine. Thank you.
Thank you, Mr. Terranova. Are there questions for Mr. Terranova? All right. Seeing none, we thank you for your testimony. And next, I'll move on to those who wish to testify neither for nor against this grouping of bills. So we'll start with, well, I guess I'll ask, is Ms. Austinfort, oh, she does have her hand up. Okay, Ms. Austinfort has her hand up to testify in opposition, I think, to at least one of the bills. Good afternoon, Ms. Austinfort. Go ahead.
Good afternoon, Senator Sanborn, Representative Tepler, and members of the committee. I'm Christine Austinfort, Director of Government Relations for Anthem Blue Cross and Blue Shield in South Portland, and I am here to testify in opposition to LDs 323, 333, 649, 849, and the insurance code provisions of 1007, 1194, and 1361, which you heard earlier today. And I want to stress that we are only opposed to the provisions of those bills that are seeking to amend Maine's telemedicine mandate. We are not weighing in on the licensing issues or any of those related concerns. We certainly support the expansion of telehealth and recognize its value. Maine has had a long-standing comprehensive telehealth mandate. The pandemic has resulted in significant increase in the take-up or utilization by both members and providers. But as I mentioned, we are proposed to some of the provisions that amend the existing mandate, in particular, requiring coverage of audio only, fax, text, email, and chat. All of those would be permitted under some of the various proposals. We don't feel that that's appropriate, but if the committee is interested in pursuing audio only or permitting audio only, we would suggest parameters similar to what were included in the proposed amendment to LD1 that you considered earlier in the session, or similar to what is in Representative Hymanson's proposal LD 849. We do have some concerns with the proposal to say as determined by the provider, because that may allow a provider to say that, the virtual providers to say that audio only is appropriate when perhaps it's not. So another option for the committee to consider might be to say that if it is medically appropriate according to generally accepted standards of medical practice or generally accepted standards of care. Sorry, I've been scribbling notes, and so I'm now having trouble reading them. I'm in a little bit of a Zoom fog this afternoon. With respect to the conversation around telemonitoring and remote monitoring, I'll bring additional information back to the committee, but there is a difference. Remote monitoring can be done by providers in other locations, such as during surgeries or potentially. So without definition, we would urge you to consider that. And finally, we are concerned about the requirements of payment parity. As Senator Sanborn noted, it does foreclose the possibility of savings. Not all providers deliver telemedicine in the same fashion. It may be parity and reimbursement may be appropriate in some instances and not others, such as virtual providers. So we suggest that that be excluded. I'd be happy to answer any questions that you may have, and I will submit written testimony to cover the rest of my comments.
Thank you, Ms. Ossenfort. Are there questions for Ms. Ossenfort? Senator Brenner.
Thank you, Madam Chair. Thank you, Ms. Ossenfort, for hanging in there today. I'm wondering if you've read or come across any studies that show overall healthcare cost savings as a result of telehealth being used widely.
Senator Brenner, I can certainly go back and check and see if we have any information to share with the committee. I do know that there are instances, for example, virtual telehealth, which is not intended to replace primary care by any means, but our members have access to something called Live Health Online, which I myself have used. And because I have an HSA plan, I have to pay out of pocket until I reach my deductible. And it cost me $49 to do a virtual visit on a weekend to address, a tooth infection that had been bothering me a little bit on Friday and by Sunday was absolutely unbearable. So I do think that there are potential savings in certain circumstances, but I'd be happy to go back and bring back anything that we might be able to offer.
Thank you.
Ms. Ossenfort, you bring up an interesting issue that I want to ask you to wrestle with a little bit, which is that insurers seem to want to kind of have their cake and eat it too a little bit in this area, which is to say you want us to deem that audio only visits can be denied by the insurer if the insurer doesn't think that they were medically appropriate, but also insurers should be allowed to incentivize their members to use audio only visits instead of in-person visits by having out-of-state sort of teledoc type services. And I guess that's a trademark, but telehealth doctor services be sort of contracted with the insurance company as a preferred way of dealing with weekend care, as you might have just indicated, because it's lower cost to the plan. So can you speak a little bit to that? Should it be up to the insurer whether we put you into an audio only visit versus whether we give you access to your own doctor in an audio only visit? It seems like that's the distinction that the insurance companies would like to maintain.
Actually, the vendor that we offer to our members, Live Health Online, does audio only is not part of that. It is a interactive audio-visual visit.
And is the concern, because I feel like before COVID, there was a little bit of a question about whether if we allowed audio only visits and called them telehealth, then the normal sort of follow-up phone calls that providers like Dr. Hymanson would have done to provide her patient with those positive test results that are kind of okay to say over the phone would have been a billable event. And the insurers were trying to guard against transforming sort of routine checkup, quick phone call. Hey, your surgery was yesterday. How you feeling? How you doing? Oh, everything's fine. Okay, no problem. Click. And then that's a billable event at $100 or whatever to the insurer. And that's what the insurer was trying to put guardrails around.
That is definitely part of it, Senator.
Okay. So concern is we're transforming things that aren't actually visits into visits by allowing for audio only.
There is that concern that things that are part of the normal overhead or part of the sort of delivery of the service. For example, if you get a mammogram, the results of your mammogram should be part of the cost of your mammogram. So that is part of the concern. I think there is also a concern that audio only is not suited to all forms of care. It works well in some instances, such as behavioral health, but it doesn't necessarily work well for a well child visit. You may need an audio only. There's also a concern with respect to, and this isn't limited to the audio only. For example, we permitted well child visits to be done through telemedicine during the pandemic because obviously people could not bring their children into the office. But there are certain aspects of that examination that have to be done in person, such as a vaccination. And so there shouldn't be a second charge to sort of complete that circle. And that's not limited to audio only. But I think the concerns are twofold. One, as you described, that there will be billing for things that are not billed for today. And two, that not all services lend themselves to audio only. And the bill doesn't, several of the bills don't provide any sort of limitation around what can be provided through audio only and what can't.
So I'm just going to ask a follow-up and then I'll get to the hands, which I see. But so my follow-up is we've now lived for 15 months almost under the executive orders that do allow for audio only. And so I'm wondering if with the benefit of those 15 months of experience, it's been Anthem's experience that providers are billing for the types of phone calls and quick check-ins that I described as the first half of the problem that you just said. There might be two problems, but just talking about that overbilling question, that issue of just the follow-up should have been included in the care kind of billing. Is that something that you have seen?
I can check on that. Off the top of my head, I don't know, but I will check.
Okay. Senator Brenner, I don't know which of you raised your hands first, but I'll ask Senator Brenner, go ahead.
Thank you, Madam Chair. Ms. Austin-Fort, without the option of audio only, how would Anthem justify equitable access for clients that don't have technology, broadband or computer with a camera, a phone with a camera?
There is audio only is permitted under the existing statute in certain circumstances. If it was a prearranged visit and the technology is no longer available and it's medically appropriate, that's in the existing law today. So that is permitted today under Maine's existing mandate. So I think that is the type of circumstance where perhaps it is appropriate. I think Representative Hymanson's proposal goes a little bit further than that. We certainly can try to come back with some language for the committee. I don't necessarily have any for you today, but.
Thank you.
Representative Arford.
Yeah, thank you so much for being with us, Ms. Austin-Fort. I'm going to ask you along the same line that I've asked pretty much everybody else. We've heard today from experts in the payer and the provider community. They've provided us with excellent testimony. However, it's interesting to note that we have not heard from one single patient who has received these services to directly report to us their experience of it. And so is there any way that you, as representing the payer stakeholder group, have an interest in really understanding what patients' experience is of this telehealth, telephonic health? And is there any way that that can be tied into whatever the negotiated payment structure is?
So Representative Arford, that's an excellent question. I would have to take that back to my provider contracting folks. I mean, certainly, it's an interesting concept. I'm trying to figure out how it would be implemented in practice. I mean, we do have, you know, performance-based incentives for providers. Measuring satisfaction on individual providers might be difficult, but it's certainly happy to take that back and get the thoughts of our provider team on that.
Okay. Thank you, Ms. Ossenfort. I don't see any additional hands. We thank you for joining us today. Next, I think testifying mostly neither for nor against is Catherine Pelletreau. Good afternoon, Ms. Pelletreau. Go ahead.
Good afternoon, Senator Sanborn, Representative Tepler, members of the committee. I'm speaking for the Maine Association of Health Plans, neither for nor against this group of bills. I'm going to truncate my comments. You already have written comments and you've heard much of what I would have said from Christine Ossenfort. I will call out just some of the wrinkles that you started to touch on. But before I go there, I just want to echo that it's tough to have a one-size-fits-all policy around telehealth and particularly around audio-only telephonic care. That said, I mean, COVID showed us that there's a really important place for it, but it shouldn't apply to everything. It's not equal to an in-person visit, and we would agree with Representative Hymanson that we do not think that parity is appropriate there. So moving on from there, onto the wrinkles. Two of these bills reference a separate telehealth deductible and making sure that carriers can't have one. So I brought that back to our members, and our members were not aware of any company doing that. But I wanted to just talk a little bit more about how they do provide telehealth services, because it's entirely accurate that they are starting to build more and more capacity to deliver online services directly. So maybe through a contract with, you know, Anthem just discussed theirs, or there's certainly Teladoc, there's MD Live, there's a lot of different ones. And I've seen different ways of administering them. So for many of our plans, those offerings are integrated into their benefit design. So whatever they would pay out of pocket for those services is going to accrue to a deductible and an out-of-pocket max, et cetera. But my understanding is that's not the case for all of our plans. There is at least one plan where it's offered as a kind of auxiliary service or a supportive service outside the benefit design. So a member has access to it, but it's a flat fee. So let's say they pay $45, you know, to call the MD Live line, or, you know, have that type of primary care visit. So it's not all necessarily integrated, is what I want to tell you, just so you have a better understanding of kind of the panoply of offerings in this area. I'd also note for you, I mean, Harvard Pilgrim Healthcare has just introduced in Maine, just maybe today or yesterday, new integrated virtual health products in the large group market. Cigna just this week has announced a giant partnership with Ginger Healthcare for behavioral health services via telemedicine. So a lot of activity. I'll stop there. Thank you very much. I'm happy to take questions.
Thank you, Ms. Pelletreau. Are there questions for Ms. Pelletreau? Representative Evans.
Yeah, just one quick question. And I've been thinking about this. Ms. Pelletreau, do you, does the industry make a differentiation between telehealth and telemedicine? Or telematics?
I think I understand your question, but I do not know the answer to how our plans define those things. Maybe, what is it permissible for me to ask you what you see the difference is? How would we define them differently?
I will reserve my opinion.
Okay. Representative Tepler, go ahead.
Thank you, Madam Chair, and thank you for being here, Ms. Pelletreau. One of the things that is confusing to me about what you are saying and our efforts to deal with all these issues around telehealth is about the fact that the practitioners seem to be saying to us, telehealth is not a specialty. It's a tool that we can use like an office visit. We either offer an office visit where you actually come in person, or we offer you a video call, or we offer you a telephone call if the video call is not possible. And that's how we'll deal with you within the medical mode that we're working, whatever that is. And yet at the same time, I'm hearing from you that that the insurers sometimes consider that sort of an offshoot, a separate thing, that telemedicine or the telehealth, as that confusion goes on, and that you might provide or contract with a service to provide that. So I'm confused between those two things, and as a patient, what am I supposed to do? And that's where my confusion lies. Can you comment about that a little bit?
Sure, I think you're onto something. Not so much, in the sense that there's one or the other, but I think both of those scenarios exist. There is telehealth that happens with existing providers for existing treatment that is happening. And there is also telehealth that occurs through, say, for example, a teledoc. So I think they both exist. It's not an either or proposition, I guess I would say.
And if I can follow up,
go ahead.
Yeah, my follow-up would be, so when you contract with a provider to build out your network, would you limit their ability to use the toolkit of telehealth to offer services and only offer those through a separate contract? Or are you going to try as an insurer to offer all of those things? And how are the costs going to be worked out?
Yeah, I mean, that's a lot to answer. I can't answer all of that. I can say that I think often the purpose of I'll call them ancillary service, is for triage. To help a patient decide if they actually need to go to the emergency room, if they should go see their primary care provider. So there's often a triage function there. What I have seen in some of the more recent products, I'll say, coming out of the health plans is pushing more towards primary care. But again, those are different than if you're seeing a provider for a service or a surgery or a series of treatments, cancer treatments or whatever, and you have an appointment with them that needs to be, via telehealth, that's also telehealth, but kind of a different category. So I take Representative Evans' question to heart, because I think there is some semantics difference here, and I'm not sure just how the health plans distinguish that. In our calls, it all seems to be called telehealth. But I'm going to take that back and see if there's a sort of a different descriptor, I guess.
Representative Matheson.
Can you hear me okay?
Yeah.
Great, thanks. Thank you. Just a quick question. When the Blue Cross Blue Shield, for example, when they contract with practitioners like dietitians, and this dietitian is the health coach, do you have any data on what the reimbursables are for those telehealth practitioners that you employ? I don't really know how you work that, but it seems to me that the billing codes are very different than what I'm used to. So could you just clarify how that works with your members?
Yeah, I can't answer that. I mean, I'll certainly take it back, but I don't know the answer off the top of my head. Is your question really getting at parity? Are you trying to understand?
It's partly parity, and also how it works in the with your members. I'm just curious. It seems like there's a value question here for parity with telehealth, of course, and there's also a question of whether or not practitioners should deem that telehealth is an appropriate access to care, but the insurance companies are deeming that they can do that with our patients. So I guess I'm confused about how that works with your members. So how do you I don't know, that's a big question, but I'm just curious how your members work with telehealth through the insurance membership.
I'll certainly take that back. On the parity question, what I have heard anecdotally from our members is that some of them do pay parity and some of them don't.
They all do right now, hopefully, because I think
Right.
that's the law.
I mean, setting aside the emergency COVID situation.
Right. Representative Arford, go ahead.
Yeah, real quickly, I'm still trying to understand what would happen in a situation where my son recently had hip surgery. He's had a great deal of pain, most of it in the evening or on the weekend. And so his surgeon has made his practices set up to be available to their patients after hours and on weekends. You can call. He's received excellent assistance on the phone. We haven't been billed for a penny of it. I mean, this is traditionally the way after hours care has been delivered to patients for years and years and years. If this bill passes, are there things in this bill, components of these bills, that would change that so that the provider industry would now be able to bill for whatever telephonic consultation they had with a patient, even if it was considered after, still what we now think of as after hours care?
I mean, I don't know the answer to that. I think that is one of the concerns. I mean, Chris Ossenfort answered this by saying that oftentimes a surgery like the one your son had is going to be covered in a bundled fashion for one rate. So it wouldn't be, you get you get charged for each phone call. It's kind of charged as a bundle, and it's up to the provider's office to figure out how to manage the cost inside that bundle.
But then I'm thinking with my primary care practice, which we've been with the same practice for over 20 years, and we've called them, I don't know how many times after hours, and gotten great advice, great help. So I don't want to belabor it, but it's something I would like to understand at some point, as soon as possible, how that would be handled.
Okay. Are there other questions for Ms. Pelletreau? All right. I think next we'll hear from the superintendent. Oh, or Mr. Yardley, actually. It looks like he put his hand up.
Hi, Senator Sanborn, Representative Templer, members of the committee. I'm waiting for Superintendent Chapa to pull the hook out, but I don't think he will. So I'll make a couple of comments. Going way back to shortly after we convened this afternoon and the a representative from the Nutritionist Association who followed Representative Matheson. I unfortunately cannot remember her name. Said that there had been some issues of insurers not paying dietitians and nutritionists at parity. We have not heard that, and so I wonder whether that's a reflection of the market that we don't regulate. On the various bills, to the extent that they deal with provider issues and put those provisions in Title 24, we think they should probably be elsewhere. We made a specific comment about that in LD 649, I think, our testimony. Stepping back for a moment, there's no question that telehealth is here to stay. Speaking as someone who has used telehealth and those people who have, it certainly there is convenience from the patient's point of view. I don't know, and I don't think we're going to have evidence for a while whether that transforms itself into cost savings at the delivery side. My computer's, I don't know why it's telling me my battery is running low, but
Oh no. Okay.
it's plugged into my docking station.
Okay.
I'll be this really fast. I think that the last year, understatement of the year, has been weird. And it's also been distorted because while there's been a huge increase in the amount of telehealth usage, there's also been a corresponding plunge in traditional delivery of medicine. And so I think it's going to be a while. My involvement with math goes to, I used to balance my bank account. So I won't speak actuarially.
Oh no. Goodness. Okay. Someone else raised their hand, but then also disappeared. Okay, Ms. Rawlings-Secunda is here to back up her colleague. Sorry, it's been a long day. That made me laugh. Okay.
Okay,
Good
so
afternoon, Ms. Rawlings-Secunda.
I'm not even very good at balancing a checkbook, so I can't go into the actuarial either. But one final point that I know Mr. Yardley wanted to present was network adequacy. This is something that we were talking about when Kate Endy testified. And we just wanted to make the point that Rule 850's network adequacy standards still apply, where we're looking at the number of providers and the geographic distribution of providers. So what we've seen from any of these telehealth bills would not impact that.
Great.
That's my only point.
Ms. Rawlings-Secunda, before the work session, or just sort of subsequent to this hearing, I think it would be helpful for us to know, and maybe it's clear because it talks about geographic area. I just want to make sure that there isn't a way under current Rule 850 to count telehealth only providers.
Okay.
And I guess it could come into play, like if somebody set up a telehealth only provider office in Washington County, in order to sort of game the system on network adequacy, but really there were no physical people in Washington County. They just had an office location that no one was ever at, but they used that in order to get to network adequacy. Did we just lose Ms. Rawlings-Secunda?
Oh, I'm still here.
Where did you go?
Where did I go?
There you are. You just stopped. You move boxes all of a sudden on my Zoom, and I'm too tired to be able to track it visually.
No,
okay,
it's like the Brady Bunch, yeah.
Yeah. So I think you understand what I'm suggesting. I want to make sure, because if we need to add a line of statute that says something like, for the purpose of network adequacy, telehealth only practices don't count. That's easy enough for us to do, and likely the sense of the committee, so that our friends in rural areas aren't forced to only use telehealth at some future date.
Okay. Yeah, we can definitely provide that for the work session.
Okay, that'd be great. And are there any questions for Ms. Rawlings-Secunda? All right, thank you so much for stepping in for Mr. Yardley. I felt so terrible when it was clear he was about to lose his computer, and then he just disappeared. All right, I think that we have made our way through the list of everyone who was intending to testify today. We have a dwindling number of folks still on the Zoom. Mr. Yardley is just rebooting his computer, I think. And we'll let him know that Ms. Rawlings-Secunda stepped in for him and did yeoman's work. Good afternoon, Mr. Yardley. I'm going to let you have the last word if you like, but Ms. Rawlings-Secunda has already helped bring us up to speed. We had a short discussion about network adequacy while you were rebooting your computer.
That's the result of a very careful consultation we had, and I will admit for the world to hear that I accidentally unplugged the power cord. It was not the computer's fault. It was unintended user error. So once again, I've contributed to inadvertent amusement and hope a moment of levity. I don't think there was anything else. Network adequacy, weird year. We're worried about cost, obviously, and who knows how telehealth is going to fit into that. But okay. It ain't like InsurTech that's scalable. This is still a retail business.
Yep. Okay.
Thanks.
Great. Thank you, Mr. Yardley. And I'm sorry that I laughed when you just.
Oh, that's quite all right. I feel like we know each other.
Yeah, it was a nice moment of levity at the end of a very long day, and toward the end of a long week as well. So thank you for joining us. I don't see anyone else who had intended to testify on this grouping of bills. And so with that, I will bring the hearing on group 4 to a close. And Colleen is with us. We do have 2 really quick, I know it's already 4:30 and we're tired, but I think that the rest of the work we have to do this afternoon is like 20 minutes max. So maybe less. So I was thinking we should just power through rather than taking a break, but if anybody needs a break, we can do that. All right. Great. So we're just going to power through. We have a couple of work sessions from yesterday's bills that I thought would be very quick. And so we wanted to just knock those out first. Colleen, remind me one of the LD numbers. And
Sure. I don't have any bill analysis prepared, so I think you can just, wing it for these 2. But the first one is LD 794, which is your concept draft to maintain main system of therapeutic foster care for children through the creation of a nonprofit risk indemnification trust. And the suggestion that Senator Sanborn made yesterday was that the committee consider carrying the bill over with a letter asking the Bureau of Insurance to convene a stakeholder group to discuss this further and report back next session.
Representative Tepler.
Thank you, Madam Chair. I will move that we carry this bill over and send a letter to is it the Bureau of Insurance we want to have create a stakeholder group? Yes, then to the Bureau of Insurance to create a stakeholder group so that when we reconvene in the short session, we will have information hopefully that will help us to resolve this really significant issue for foster care.
It's been moved and seconded by Representative Matheson. Is there any further discussion on the motion?
Just a question, what number was that?
It's 794.
Thank you.
You're welcome. All right, the clerk will call the roll.
Representative Quinn.
Yes.
Representative Quint, yes. Representative Connor. Representative Connor is absent. Representative Blyer.
Yes.
Representative Blyer, yes. Representative Morris.
Yes.
Representative Morris, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Melorano.
Yes.
Representative Melorano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart. He was here. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler.
Yes.
Representative Tepler, yes. Senator Sanborn.
Yes.
Senator Sanborn, yes. That is 11 yes, 2 absent.
All right, so we've now spent officially 2 of our 13 carryover bills. And so, you know, as we're getting requests to continue carrying over bills, please do keep that in mind, that we've got a budget of them. Representative Tepler, go ahead.
Thank you, Madam Chair. I do want to indicate to you that at least the Speaker of the House has indicated to me in chairs meetings that they may not consider our mandates in that number 13. So we may be able to carry over a few more bills than we thought we could.
Okay, that's great. I have not, all I got as an answer to that question was we'll check with the House. So I haven't heard back, but so that's good information. Thank you.
Mm-hmm.
All right, and the other bill is LD 1614. Colleen, can you read the title for us?
Sure. This is an act to mandate that certain healthcare providers disclose an estimate of charges at the time of service. And you might recall we had a discussion of a number of bills, 4 or 5, during our marathon work session day that proposed various versions of this same type of proposal about expanding the requirements for providing estimates and providing information about costs of hospital services. And we talked about sort of the new federal rules that are going into effect in addition to the upcoming requirements for health insurance carriers to provide information about shoppable services in plan year 2023. All of the bills you previously discussed on this topic were voted on not to pass unanimously.
Is there a motion? Representative Tepler.
You're muted, Representative.
Representative Tepler is muted.
I'm sorry, I keep muting myself when I mean to unmute. Thank you. Yes, I will move ought not to pass on this bill, although I do have to say that I haven't had a chance to talk to the sponsor.
I did.
Oh, you did? Okay, good. That's helpful. Thank you. You know, I think that after all the federal stuff settles, we might want to talk about disclosure for uninsured folks of an estimate of costs in some settings. But meanwhile, I think we have to move towards waiting to see what the federal laws will do.
Colleen, can you give Representative Tepler some information about what's already in statute?
I can. We already do have a requirement for hospitals to provide estimates to uninsured patients upon request of the total cost of care, sort of an episode of care, what the statute describes. And so the hospital is supposed to provide those estimates up front, and then also identify any third-party providers that would be part of that episode of care. So that is already part of our current law.
Okay, good to know.
Representative Arford.
So if I want to make a comment about this bill, do I make this now or wait till the motion has, we have a motion on the before?
Let's just get a second, just so that Christian can put it on his sheet. And so that was Representative Evans seconded it, and Representative Arford, you can go ahead.
Okay, so quickly, I did speak with Representative Grayson about this last night. I think he understands that we have this federal law coming down the pike and we need to really understand that before we pass anything. However, he and I both agree that price transparency should be a policy that we continue to look at and that we do whatever we can to promote that. And I'm very much in agreement with him on that.
Okay. Are there any further comments on the bill? All right, seeing none, the clerk will call the roll.
Representative Quint.
Yes.
Representative Quint, yes. Representative Connor. Representative Connor is absent. Representative Blyer.
Yes.
Representative Blyer, yes. Representative Morris.
Yes.
Representative Morris, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Melorano.
Yes.
Representative Melorano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler.
Yes.
Representative Tepler, yes. Senator Sanborn.
Yes.
Senator Sanborn, yes. That is 11 yes, 2 absent.
Great. So Colleen, you've got some language review. Do you want to share your screen?
Sure. Thank you.
Yep.
I have a few language reviews to share with the committee really quickly. The first one is LD 1320. This was the bill that relates to allowing banks and credit unions to hold virtual meetings. We voted the bill, you saw the language, which was just really clarifying the original bill, the intent that it would apply to credit unions. So we added 2 sections to make that happen. I wanted to point out the fiscal note. Any minor costs to the Bureau of Financial Institutions can be absorbed within their existing budgeted resources. But I did want to mention one thing, and if the committee would want to consider adding an emergency preamble. It was something that I suggested as part of the bill analysis, and when you took the vote, I neglected to sort of ask and clarify that with the committee. So I didn't know if that's something, since it was unanimous, it's something the committee might want to consider adding on now. If everyone is in agreement, I don't think you need to take a formal reconsideration, but it's just a suggestion that it may be helpful for if it was enacted as an emergency.
Yeah, I would recommend this to the committee just because it's possible that the current state of emergency could end prior to the effective date of all the bills this session. I have no idea when it'll end, but it could. Representative Morris.
Yes, thank you, Madam Chair. I'm certainly fine with adding an emergency preamble.
Okay, great. I can't see everybody's face. So if you're not okay with it, if you'd raise your electronic hand at this time. All right, I don't see any hands. So I think that makes sense, Colleen. And I actually think we're gonna have a couple of these coming up.
Yeah, there may be a couple others, but this was the only one in this one today, I think.
Yeah.
Okay, so the next one, just moving along, these are the amendments to LD 1115, which is an act to improve access to HIV prevention medications. You had seen this language when you took the vote, but hadn't had the fiscal notes on it. The difference between the majority and the minority report is the minority report removes the insurance provision of the bill, but otherwise they are identical. But I did want to share with you the fiscal information on the bills that came from the Board of Pharmacy. The fiscal note would be the same on each amendment, but they do believe, which was alluded to as part of your discussions, of the need to add a half-time position to account for the additional workload. So it does add an allocation to their other special revenue funds, and you can see the amounts there. I did also want to note that they believe they have the existing funds and resources to fund these additional allocations, but they did note that there is a potential for fees to need to be increased in future biennia if their current fee structure doesn't generate the sufficient revenue to cover the cost of this legislation. As I mentioned, the fiscal note on each of the majority and minority reports is the same. So I wanted to point that out to you.
Thank you, Colleen. And so there is no fiscal note associated with the mandate.
No, I have not. I should follow up, but I did not receive any information from them about the insurance piece with regard to the state employee health plan. But I will follow up with the fiscal office because they may have overlooked that. So I'll double check.
I think that's probably right because it's
I
already.
think so too, but usually they say something, and you raise a good point. Usually they say something in the fiscal detail about it. So I'll just double check and confirm that. I wouldn't want you to be surprised by something later on. So
My other question about this is that I think this is the same fiscal note that's on the long-acting injectables
it is.
bill. And so I guess my question is, if it's the same person, is it halftime on each, or is it the same person and they just want to put it on both because one bill might pass and one might not?
Yeah, I'll have to follow up because you haven't, even though you've taken the vote on LD 1293, which is the injectable bill, and you that this is consistent with the preliminary information you received on that bill, that bill will go through another loop. And so they'll take into consideration the fiscal notes that's been added on here. And so I'll double check if it's the other half of a full, if it's a full position or if that's going to be sufficient to cover both. And so this one is just the one that came first.
Yep.
That's my
Okay.
understanding. So
go ahead.
Okay. All right. So the next one is LD 504. This was the bill that changed or required the Department of Health and Human Services to change their certification for mental health rehabilitation technicians. You amended the bill only to add an emergency preamble, which is here. And then I just wanted to quickly show you the fiscal impact, a potential minor cost increase to the general fund. Any additional costs to adopt the changes in the bill are expected to be minor, can be absorbed within existing budgeted resources. Although this does note a minor cost increase to the general fund, my understanding is because it is a minor cost increase, it's not a bill that would be referred to the special appropriations table prior to its enactment.
Great, thanks.
So that's 504. The next one is LD 1141. This was a bill that related to service contracts. You had asked that I work with Mr. Garrity and the Bureau of Insurance to work out some of the technical issues associated with this amendment to the bill. We've changed the title to reflect the focus of the original legislation has been narrowed to just add replacement of motor vehicle key fobs and damage to a motor vehicle that results in lease end or other charges. After further consideration, Mr. Garrity and the Bureau of Insurance, they've opted to take out the provisions in the original bill that related to theft protection programs. I think they'll come back to the legislature with suggestions for potential future legislation in that area. So the amendment just makes the changes that you discussed that were in the original bill that just strictly focus on adding to the ability to provide as part of a service contract replacement of motor vehicle keys and key fobs and damage for leased vehicles. And the fiscal note is no fiscal impact.
Thanks.
Yeah. And then the last four are all the bills that related to repealing provisions of the certificate of need process. The committee's vote on all of these bills was ought not to pass the majority report, and each had a minority report of ought to pass. So I have the fiscal notes on each of these bills. LD 932 is an act to increase hospital capacity by eliminating the CON for hospital beds. For this bill, there's no fiscal note required. With regard to LD 931, this is would eliminate the certificate of need for outside hospital beds. Here, the Department of Health and Human Services has added a fiscal note to reflect what they believe will be increased costs in the main care program. related to repealing the requirements. So there is an expectation that there will be new licensed beds or increased beds added in healthcare facilities other than hospitals. And as a result of that, they'll have additional main care expenditures. So the minority report would add a fiscal note to provide for these general fund appropriations. And then there are some corresponding federal fund expenditures because the main care program is funded through both state and federal funds. So that's LD 931. Similarly, with regard to LD 935, this is, we would repeal the CON for healthcare facilities. Again, they expect the potential for the creation of new facilities that might otherwise have been restricted if they had to go through the CON process. So there's also a corresponding general fund appropriation with regard to LD 935. And then lastly, LD 1004 would eliminate the certificate of need for major medical equipment. And again, they anticipate by repealing these requirements, there may be expansion of the purchase of this major medical equipment that will lead to increased potential for increased main care costs. So those are the last 4 that I had for you. I'll stop.
Thank you.
You're welcome. That
All
was
right.
it for me.
I do want to update the committee that LD4, which we had previously had a hearing on and voted, we are going to kind of reopen the contents of the bill. An issue has been identified related to, it's a pharmacy board bill, and an issue has been identified related to the way that Maine deals with compounding pharmacies for veterinary practice. And we have some large veterinary practice or technology companies in Maine. And we have a problem with our statutes. So with regard to those. So next week at some point, we will be having a work session, which is really kind of a mini public hearing on the additional language with regard to compounding for veterinary purposes. And with the anticipation that we would further amend LD4 to make sure that we can bring our veterinary pharmacy practices up to where they need to be for our companies in Maine, in my district. So with that preview, I think that is the end of our work for today. It's not even 5 o'clock yet, but I would suggest perhaps that Colleen and Christian and Denise and I could get next week's schedule ready this afternoon. So you should see that soon. And thank you, everybody. And we'll see you next week.
Thank you.
Thanks, everybody.
Christian, you want to send another link or do you want to stay?
Have a great weekend.
I'll send a new link.